Ayun, may PUI.
Ingat ka
Okay.
dyan. Nasa pikas ba kayo?
Yes po.
Okay.
Jeffrey, just let us know. We can go.
Okay, so good afternoon. I think, Mon, we can start now.
Okay. Good afternoon, everyone. On behalf of Palace Board, let me welcome all the participants to the pre-Congress activities of the Palace 2020 Virtual Congress. We are celebrating our 10th annual Congress, pandemic withstanding by going virtual. Before we start our program, may I call on Dr. Mon de Vera to lead us in prayer. Dr. de Vera?
Yes. On ko lang yung video. Okay. Before we pray, let me read Psalms 92. It is good to give thanks to the Lord, to sing praises to thy name, O Most High, to declare thy loving kindness in the morning and thy faithfulness by night. With a 10-stringed lute, with a harp, with resounding music upon the lyre. For thou, O Lord, hast made me glad by what thou hast done. I will sing for joy at the works of thy hands. How great are thy works, O Lord! Thy thoughts are very deep. Let us pray. Blessed are you, O Lord, our God, King of the universe, sovereign over all. We bless your name, O Lord, and we are truly grateful to you for having kept us all safe and alive and protected from the COVID pestilence through our 4 months of quarantine. We thank you, Lord, for making it possible to have our 10th annual Palace Convention, a virtual Congress, through the able leadership of our President, Dr. Ernesto Tan, and the cooperative efforts of our officers and board of directors, and the excellent work of our organizing committees. O Lord, do bless our pre-convention sessions today. O Lord, do grant our expert lecturers wisdom and clarity of delivery and an effective reception of this information to our participants. We all ask all these things for your glory in the mighty name of our Lord and Savior Jesus Christ. Amen.
Amen. Thank you, Dr. de Vera.
Amen.
To welcome our participants and open the session, followed after is his talk on Palace Fellows requirements. Please welcome our President, Dr. Ernesto Tan.
Thank you, Mohan. Good afternoon, everyone. Welcome to the virtual pre-congress of the 10th PCS Palace Convention. The topic, Palace Guidelines, what you need to know, and Palace Zero BDI campaign are very appropriate and timely since we get some inquiries regarding this, especially requirements for fellowship and accreditation. Timely because we are just finalizing the administrative manual, and your inputs and comments on these topics are very important and will be highly appreciated. With this COVID pandemic, we have to adjust and adapt to the new environment and situation in order for us to deliver the best quality care to our patients, at the same time protect ourselves, our co-workers, our patients, and our families. We have to be prepared, ready, at the same time cautious, also in doing our work. I think this new normal will stay with us for quite some time. And therefore, we have a long battle to prepare. Once again, welcome to the session of Palace Zero BDI campaign and guidelines. I'm sure that this will be a fruitful, informative, and productive day. Enjoy the rest of the convention and hope to see you all in the next 2 days. Mabuhay.
Thank you, Dr. Tan. So, sir, we can proceed with your with your presentation.
Thank you again, Mon, and a pleasant afternoon again. My assigned topic is Palace guidelines, what you need to know and requirements for application. As I said, this topic is very important and very timely. It should be emphasized and reiterated every now and then, since there are some inquiries why some applications for Palace Fellowship are not successful or are being turned down. These are the basic or minimum requirements for application for fellowship. It's all in the Palace website. But just to reiterate, these are the requirements. Medical school diploma, PRC board certificate, valid PRC license, certificate of residency training, specialty board certificate, certificate as fellow of PCS, certificate of completion of a course on basic, advanced lab, or certificate of training in laparoscopic surgery. Preceptorship certificates signed by a certified preceptor of Palace, 10 assisted, 10 performed with histopath report. Accomplished application form, application letter addressed to the director or committee, chair of membership and credentials. Chapter endorsement. Submit 5 names of Palace Fellows with corresponding emails. 5, an edited video of lab collect performed within the last 2 years. Follow the Palace standard purportedly in achieving the critical view of safety. 2 PCS 2x2 ID in an application fee of 1,005. As you can see, number 13 is highlighted. Since most of the disapproved application is due to the submitted unedited videos. I'll get back to this in detail later. So this is the flow of application. This applicant submits all the requirements to the Secretariat Office. This will be evaluated by the Committee on Membership and Credentials, headed by Dr. Mono, and together with his team are doing a great job. Imagine reviewing 3 to 5 unedited videos per applicant, and it takes around 1 to 2 hours per video, with no more or less an average of 30 to 40 applicants. It's no joke. Kudos to you, Dr. Ong, and your team. Their recommendations are then submitted to the board for approval. And the applicant will receive communication from the board whether the application is approved or not. In cases where some applications are not approved or held in abeyance, this is mostly due to submitted unedited block caller procedures. So these are the basic criteria for evaluating the videos. Trocar placement, dissection and hemostasis, critical view of safety, clipping of artery and duct, and specimen delivery. And these are the details. This is actually a checklist for evaluating the videos. As you can see, they check the abdominal wall access and scored 0, 3, or 5. Limited diagnostic laparoscopy, subsequent trocar insertion, gallbladder traction, landmark identification. Again, the scores is 0 to 5. Exposure of the critical view of safety. 0 BDI timeout, clipping, and cutting, gallbladder dissection. Extraction, specimen evaluation, and closure. So as you can see, again, number 7 is highlighted. The score is either 0 or 5. There is no in between. So if you miss item 6 and 7, that's already what? 7 times 5? That's already minus 35 points. As you can see, this is not arbitrary. And it is done in every video submitted. So you can imagine how tedious it is. In order to have more or less a standardized evaluation and to be fair to everybody. There is no bias, nothing personal, since these are unnamed applicants and institutions, only assigned numbers. Most of the disapproved applications are due to failure to demonstrate or to achieve clearly CBS with no 0 BDI timeout. So the tip is to submit uncomplicated lab call videos and try not to impress by submitting complicated lab caller procedures. And please ask your preceptor or trainer to review it, since they affix their signatures in the submitted operation. So the committee initially randomly picked 3 unedited videos. And if they are not satisfied with the videos, then that's the time they will review all the 5 videos. In some instances, wherein the committee cannot decide or make decision, then the board will review the videos. Of course, again, only the numbers will show, no names, and no mention of institutions. So this is more or less the process of evaluating applicants. So right now, we have 879 fellows, 22 certified preceptors, and 95 trainers, plus 19 incoming fellows who will be inducted tomorrow. That will make us a total of 898 nationwide. So for the requirement of the preceptor, the preceptors and trainers do not apply and only are invited, or it's only by invitation. So these are the requirements for preceptors. So as I said, this is by invitation. Curriculum vitae with photograph, certificate of fellowship of PALES, must be a fellow of PCS and PALES in good standing, must be active PALES fellow, attending the PALES annual convention every year. Any preceptor who is inactive or have missed 2 consecutive PALES annual convention will be automatically delisted from the rest of preceptors, but will remain fellows. 100 laparoscopic cholecystectomy cases performed and 20 laparoscopic appendectomy cases after he or she became a fellow of PALES, of course, with histopathologic report. Again, you are required to submit 5 unedited video lap cholecystectomy performed done in the past 2 years. 2 simple, 1 difficult, and 1 bail-out case of lap chole, and 1 lap appendectomy. Follow the PALES standard 4-port technique, achieving the CBS. 3-port technique may be used for as long as you show or achieve the CBS. Submit 5 names of PALES fellows with corresponding email addresses and hospital affiliation. 3 from the area of practice and 2 from PALES board or preceptors or trainers of PALES. And these are the requirements for trainers. Again, this is by invitation. Must be a recognized active preceptor of PALES, recommended and trained at least 5 trainees who became fellows of PALES. Must have been faculty in at least 3 basic lab workshops conducted by PALES. Curriculum vitae with photograph, certificate of fellowship of PALES, must be a fellow of PCS and an active member of PALES in good standing, attending annual convention of PALES every year. Any trainee for that matter who is inactive for or have missed 2 consecutive PALES annual convention will be automatically delisted from the roster of trainers and preceptors. So, required again to submit 10 unedited videos of lap surgeries performed. 3 simple, 2 difficult, and 2 bail-out cases of lap cholecystectomy. 2 simple and 1 complicated lap appendectomy cases. Then follow the PALES standard 4-port technique in achieving the CBS. 3-port technique may be used for as long as you can show or achieve the CBS. Submit 5 names of PALES fellows with corresponding emails, 2 from area of practice and 3 from PALES board, preceptor, or trainer. I think that's my last slide, and we'll gladly entertain a question later. Thank you again and have a fruitful virtual convention. Enjoy the rest of the convention and see you all again in the next 2 days. Mabuhay ko.
Thank you. Thank you po, Mr. President. Please reserve your questions for the open forum. You may type your inquiries on your chat box. And now, to talk on the accreditation of institutions for basic laparoscopy is our head of the accreditation committee. Please welcome Dr. Alex Palinis.
Thank you, Mon. And good afternoon to all the fellows and guests. I have been tasked to present the existing guidelines which have been used to accredit the 19 institutions So in 2006, six institutions applied for accreditation. And these are FEU, Jose Reyes, St. Luke's, UPPGH, UST, and Veterans Memorial Medical Center. In 2011, 7 institutions were added to the roster. They are the Batangas Medical Center, Metropolitan Hospital, Pasig City General Hospital, Rizal Medical Center, Martin de Porres, the Medical City, and UERMMC. 3 years later, 4 were added, and these are Mary Johnston, Chinese General Hospital and Medical Center, De La Salle University Medical Center, Southern Philippines Medical Center. And in 2015, only 1 joined, and these were Cebu Doctors University Hospital, and in 2016, the Perpetual Health Delta Medical Center, for a total of 19 institutions. The board felt that it was time to review, fine-tune, and revise if needed. In fact, it was included in the issues to be discussed in the strat planning scheduled early this year. But because of the pandemic, the activity was postponed. So here are the guidelines that we applied in the 19 institutions. Number 1, it must be a PSGS accredited training program. The hospital must have available complete laparoscopic instrument and equipment. They should meet the requirements identified by the association. The senior residents are only eligible for certification. They should train only their residents, and no lateral entry will be allowed unless they are part of the accredited training institution. Their hospital must have an animal laboratory or alternate room for live surgery that complies with the Animal Welfare Act of 1998, or an alternate facility for skills lab. They should follow the standard program of the association with skills lab that may cover any of the following: lab trainer box, virtual trainer, cadaver lab, didactic sessions, video clinics, and or animal laboratory. Their faculties must be fellows of PALES and recognized preceptors or trainers. At least one of the recognized trainer must come from each hospital and not from other hospitals or institutions. This is to ensure that after the workshop, the residents will be properly supervised by a qualified preceptor or trainer. Majority or 50% of the faculty trainers, these are those who attended the faculty accreditation workshop, should be coming from the institution or institutions involved in the workshop. They should include the names of the association in the program, whether they invite PALES faculty or not. These are the documents to be submitted. The letter of intent applying for accreditation, census of lab cases done by residents and consultants for 3 consecutive years, the list of residents and year level, list of faculty and their category, whether they're preceptor or trainers from the hospital, copy of existing MIS curriculum or program of the hospital, and picture of the facility or skills lab. And each accredited institution is required to submit their annual report. PSGS has 71 accredited training institutions, and 19, as I mentioned a while ago, out of the training programs are accredited by PALES. Upon satisfactory completion of the GS training program, the graduate of the 19 PALES accredited institution can already apply for associate membership. The rest of the 52 training programs, their graduates must either join a PALES accredited workshop on basic laparoscopy or undergo a preceptorship. The board in its last meeting unanimously approved the validity of the accreditation status of all 19 accredited institutions until the end of 2020. And after 2020, when the conditions permit, the new board, through its annual strategic planning, will review and assess the accreditation guidelines. And these are the matters to be discussed during the strat planning of the new board. Template of annual report, physical visit, which has not done before. This is to verify what is written in the annual report. The minimum requirements to maintain accreditation and the validity of accreditation. Like how many years will it take for until the full accreditation expires? Deficiencies and sanction. I think that is my last slide. Thank you very much.
Thank you, Sir Alex. Our next speaker is a member of the PALES Board of Directors. He is the committee head of this annual Congress to tackle on the process of accreditation for advanced MIS. Please welcome Dr. Jeff Domino.
Okay, good afternoon, Mon. Can you hear me? Yeah,
Yes.
thank you. So good afternoon, everyone, and welcome to the PALES Fellowship, MIS Fellowship Council. So I was tasked to give a short talk about the PALES Fellowship MIS Council. Okay, so the PALES Fellowship Council was actually proposed by the board of directors, especially under the committee of the accreditation. And the objective of the MIS Council is to be an accrediting body by the board of directors for the MIS fellowship program. But this is a recommendatory body, and it focuses more on the advances already. So we're now going or moving forward from the basic MIS or laparoscopy to an advanced MIS program. It monitors or plans to monitor the trainees and the programs for quality monitoring, mostly on the advanced cases that will be identified later on, especially that when we present this to the new board of directors on the next board of directors group. It shall also promote the continuous well-being among the patient to ensure that, as well as the safety outcomes for all the patients by or done by the fellows doing advanced MIS. The composition of this MIS Council, as it will be proposed to the next board of directors, it still be under the committee of accreditation. And the board of directors, or one of the board of directors that will be in charge, will be appointed by the new president as well. And it's composed of the heads of the MIS fellowship program, especially the ones that are existing. So for this year, there was already a meeting done when we did our strategic meeting in Bohol, wherein it was decided that in order to monitor this unified MIS fellowship program, it has to be, the composition should be with the current MIS directors or the heads of the MIS programs that are already been approved by the board of directors. And this is a recommendatory body, as all recommendations of the committee will still be subject to the approval of the board of directors. The function of this MIS Council, well, it sets guidelines for accreditation. So we know that not all has the same resources. So that's one challenges that we have to face. Not all has the same staff. No. Some have still have lacking personnel or expertise, but it's because of this MIS Council, we will be able to identify the weakness of the other institutions, especially those who really want to start an MIS, advanced MIS program. Another function is to approve the accreditation once they're evaluated, and monitors this accreditation either every year or every 2 or 3 years, depends on what the council has decided. Because at this point, it has not yet been decided on how many years is the visit or the renewal. The renewal of accreditation, such as one of the possible or a proposal was to maybe put some visiting teams to really check the data, the resources, the facility as well. It shall review the policies and the standards of its fellowship program if it's really properly implemented, as well as what other resources that can be approved or can be improved. It shall resolve issues, especially those with conflicts, especially those with weaknesses in terms of resources or staff, especially with the requirements. And nowadays, one of our issues that are facing are the consortium, the merging of other hospitals. So these are issues that can be that shall be taken up by the MIS Council. And with this, we will be able to plan future directions and what would be the best program that could be adopted by our country, as well as the different MIS programs. Of course, what's the initial accreditation? You have to submit a letter of intention to start a fellowship program to the PALES administration or to the board of directors. This will be assessed, of course, with the capability, and as well as there's a possibility of a visit, or visiting the hospital or the facility where the program should be done. And of course, whatever the requirements that has been found or the evaluation, still for approval of the majority of the board of directors. So at the moment, it is still a proposal because this will be submitted to the next, or it will be tackled by the next board of directors after the election. And at the moment, the present accredited MIS fellowship programs are from the Asian Hospitals, Focal, St. Luke's, and the new one is the university or the unified MIST. From it started with RMC, now it's with unified MIST. So that's it, Mon. Back to you.
Thank you, Jeff. So the panel is now open for discussion. May I invite Dr. Ray Sarmiento, one of our board of directors, to moderate this session.
Okay, Mon.
Joining the panel will be our president, Dr. Tan. Dr. Palinas is here, as well as a member of the Palace Unified MIS Council, Dr. Miguel Mendoza. Ray?
Yes, thank you, Mon. Good afternoon, everyone. So,
Afternoon.
in the chat box or in the Q&A section, there's only one question posted. Let me post the question first. It's from Dr. Elises. Clarification: for a fellow requesting a certificate of good standing, is he required to submit 20 videos? Probably this is regarding the maintenance of membership as mentioned by Dr. Tan. Can I post the question back to Dr. Tan?
Yes. Can you hear me, Ray? Ray, can you hear me?
Yes, sir.
Okay. So to answer your question, I'll post the requirements in order to be in good standing. There are only three actually. One is that payment of dues. Two is attending the annual convention. And lastly, the submission of 20 lab procedures. So I'll just show you the slide. Please wait.
Yes, sir.
So, sir, hello.
Yes, yes.
So, sir, I think the slides are
The
clear.
answer is yes.
Yes. You will need to submit 20 laparoscopic procedures every 2 years.
Every
And-
2 years, yes.
And that will actually put you into good standing, and then Palace will be able to release a certification of good standing once all of these are filled up, or once all of these are already done.
Okay. Can you see the
Sir, just a point of clarification. Is it a list of procedures or submission of videos?
list of procedures only?
Just a list of procedures. Okay, Dr. Elises, did that answer your question? Okay, thank you. Another question from the Q&A box from Dr. Danak. Are there provisions in the proposed accreditation for those who have already finished an MIS fellowship and those who are currently undergoing fellowship who would like to apply for a Palace fellowship?
Ike, you want to answer on that?
Ike or
Mendoza,
Dr.
are you here?
Palines? Okay.
Dr. Palines, you want to answer on that question?
Can you repeat the question?
Ray, can you repeat the question, please?
Okay, question is, are there provisions in the proposed accreditation for those who have already finished an MIS fellowship program and those who are currently undergoing fellowship program? Are there provisions wherein, probably this is with regards to a full Palace fellowship and a associate fellow?
Dr. Salinas?
MIS fellowship.
So, Jeff, can you answer that? Dr. Palines said it's about MIS fellowship.
Thank you, Mon. I think the question is about is it fellowship for advanced MIS or fellowship for PALES? So for fellowship for PALES, I think we have minimum requirements. No, so if they were able to achieve the results, I mean the requirements set by Dr. Palines, there's no problem with that. The problem is, will it be what you call this? Will it be accredited knowing that you did your fellowship from abroad, diba? So yes, there's no such thing as provision, but it will be evaluated because the ones that will evaluate, which is the board of directors as well as the group of accrediting committee, will evaluate from what institutions they came from. So the problem is there are different types of institutions abroad. Then it also depends on the programs. So that's why there is no standard yet because it depends on what institutions. However, as previously mentioned before by Dr. Mendoza, that it will be evaluated by the board first. So what are these evaluation? What institution, what program, and how long? So these are usually the provisions or the metrics that will need to be evaluated. Ray?
Thank you, Jeff. Okay. Okay, here's a question, an interesting one from Dr. Quijada. Are there any provisions for those not doing LabCole but would like to apply for fellowship in PALES? Let's say they just do laparoscopic colorectal procedures to be a member of PALES. Do we have provisions in terms of how they become fellows or members of PALES?
Yes, there are provisions, and the requirement for applying fellowship has been shown earlier, and they still should submit unedited videos for evaluation. I'm not so sure whether she's doing advanced laparoscopy.
Kuya Ray, can I answer that?
Okay, sige Mon.
Simon, sige.
Yeah, okay. For those who have a specialty like colorectal, pediatrics, they can apply for to PALES as long as they are endorsed by their society, and the credentialing will depend on the society, on their proficiency on the different procedures. Once they are endorsed by their society to PALES, then we just admit them as fellows.
Okay, Mon, thank you. So clear. So we would just like an endorsement from their mother society, and then we will give them it will be reevaluated by PALES and then given the fellowship as per recommendation of the society or their mother society. Okay. Question from Dr. Abratike. Will the maintenance of good standing requirements, when will it start? One?
So usually the good standing, we already put in our guidelines that they must attend the annual convention at least 2 in 3 years or 1 to 2 in 3 years. And then the previous requirement of 20 LabCole cases yearly. So I think that's only the requirement to maintain your good standing. The most important is you attend the convention and you pay your annual dues.
Okay, Dr. Mon, will that requirement start this fiscal year right after this 2020?
Actually, it's been implemented last year, but the official implementation will be from 2020 onwards.
Okay, thank you. So I think that will be clear to our membership that it started already last year, but now I think with this virtual congress, we have reached around 309 participants, and it's clear that the accreditation will start 2020. Okay. All right. Regarding another question from Dr. Axel. Dr. Axel from Cebu, right? Regarding submission of video procedures done, how can we avoid conflict with the Privacy Act or the Data Privacy Act?
Yes, that's actually a good question. No names of the patient, and this is good only for a certain duration. Okay? Specific purpose is for application. But that's the requirement for the data privacy. No names, no identification, no institution, and with a specific purpose for a certain duration only. Once it's done, then it's erased.
Okay, just a follow-up question with that, sir. Some hospitals do not allow video recording as part of their policy. So how do we go about that? Of course, they can apply. I think maybe they can send their videos coming from hospitals where it is allowed. But how about when most of the cases that the fellow is doing is in a hospital where it is not a policy to do video recording?
Okay. So I think, Ray, actually, we cannot really impose recording if the hospital does not allow it.
Yeah.
So I think the fellow who is applying should find a way to at least record 5 videos. So one way is using the phone to record the important parts, which will be discussed later, the 12 steps that we need to see in the video. So even if it's by clip, the video clip, there's no problem with that. As long as we see the 12 important steps to evaluate the fellow. So we do not require a high definition recording. As long as we can see clearly the technique, there's no problem with us. So a phone recording is enough.
Okay, Mon, thank you. So that's clear. Phone recordings are accepted. Just make sure that it is your real case or your personal case. There's no more question in the chat box or in the Q&A portion, but I encourage all our participants to post their questions. In the meantime, may I just clarify a few things? Dr. Tan?
Yes.
There was mention regarding most of the applicants this year who had their video submitted. Some were denied admission as fellow or member of PALES, mainly because of the submitted videos that they gave PALES. And it was evaluated as shown. There's a criteria with regards to the videos that they submitted. But how much weight do we put to that video recording or to that video submission with regards to being accepted as a fellow of PALES? Is it 100%, 50%, and then the others are due to our academic certifications? Others it might include endorsement from the program director. So how do we? How much weight do we put to this video submitted?
Okay, so some of the not approved or holding abeyance are based on the videos, unedited videos submitted. Okay? So as I said, there's a existing scoring system, and perfect score is something like 190. It's 0, 3, and 5. Right? And 70% or 133 above is considered passive. So below that, it's failure or not approved but they can or they are asked to submit subsequently other videos to reapply. Okay? And then this will be evaluated again. As I said, most of these questionable videos, I should say, is coming from a complicated lab college. So for those applying for fellowship, just submit uncomplicated college, and that's okay.
Okay, sir. Any any clarification from the floor or from the audience? Okay, let's wait for any questions to be posted. But here's a question in the Q&A box from Dr. Pagdanganan, Makati Med, Asian. Regarding annual submission of the 20 cases for a fellow, what is the format? As you mentioned, no patient identifier. So, Mon?
Yes. So actually, yes, Ray, the format of the 20 cases is still not finalized. But as with the recommendation, we just need the it's a coded video, like video number 1, video number 2. You don't need to submit the names or even the age or even the what type of case. Just send us lab cole, what you did, if you have lab cole converted to open, like that. No? So we just want to know that you are actively practicing laparoscopic surgery. So we don't need the details.
Okay, Mon. So, no identifiers, maybe just a number of cases, number 1 to 20, and dates probably. Would that suffice, Mon?
Yeah. So anyway, the
Hospital,
board
do we
will
need
set.
to the hospital where it was done?
Actually, we don't need to put the name of the hospital because some surgeons are doing a lot of cases in different hospitals. So we will just accept the case.
Mon, here's a suggestion from Kati. Maybe we should provide a format for our
Yes,
membership.
we will.
Just like a
we will
pro
do that.
forma for, okay. So to our participants, we are doing this to clarify all questions with regards to membership and accreditation of programs, so that there'll be, all your questions will be answered. So we'd like you to post your questions. So while all of the board is here, and while some members also, or members of each committee, is here to answer all your queries. Okay. So we have an approved Dr. Ate or our Prexy from APHB, PAPSI said thank you to that suggestion, Mon. So any question or any Dr. Ike?
Ike?
Yes, hi.
Okay, any Dr. Ike is one of the pioneer surgeons who developed or opened up a advanced MIS program. So any clarification or any points you would like to convey to our participants, to those who would like to open an advanced MIS program in their institution?
Yes, thank you very much, Ray, and thank you to the committee as well, and Dr. Tan for clarifications mentioned a while ago. Yes, for those who are interested in opening an advanced MIS fellowship program, the guidelines have been discussed, and this will be fine-tuned in the strat plan. What's important is to consider the following. One, you have a dedicated program director who has been adequately trained to run the program. You have the number of advanced MIA cases available. You have a good set of designated faculty who do advanced MIS in your hospitals. You have set up a program for didactics as well as a program for skills training. And if there is a component of the teaching component, such as postgraduate courses, workshops, webinars that your fellows can conduct together with the faculty, that would be a very good addition to your fellowship program. One more thing is something that we look into would be the support, of course, coming from the administration or management of your hospital. So those are a few of the general ideas on how to start an advanced MIS program.
Okay, Dr. Ike, thank you for that. Here's maybe a question that's related to that from Dr. Benedict Valencia. Can an interim program, like an interim GS program, maybe this question is for Ike and Dr. Palines. Can an interim program apply as early as now as an accredited laparoscopic institution, even though they don't have senior residents who are operating or doing laparoscopic surgery yet?
Yes, maybe Dr. Tan,
Yeah,
would you like to answer that question, please?
Ray,
Yes, sir.
for the basic MIS training program, accreditation of PSGS is required. So it must be accredited by PSGS in general surgery for an MIS basic. But for unified, it's not required.
For the interim program,
Okay.
it is very clear in the accreditation guidelines for institution that the 5th years will are the only one qualified to get the certificate of completion. Now, the interim program, when it reaches the full accreditation, meaning they have a complete set of residents from 1st year up to 5th year, they can apply for accreditation. But if they're only starting right now, they have only 1st years as residents, they cannot be accredited.
Yes, only accredited PSGS training programs is qualified to apply for MIS training program in basic MIS.
Okay, sir. So let's clarify that. For interim programs, I think they just have to build up their census. And once they get full accreditation, they can apply for an MIS accredited institution or a PALES accredited institution. Is that the message you'd like to convey, sir?
Yes.
Right now, we have a total of 93 PSGS accredited training programs. 71 are those who have regular accreditation, and the remaining 22 are interim accreditation.
Interim programs. So those interim programs cannot apply.
Yep.
Until they have reached the
Regular
5th year
accreditation.
status where their resident complements are complete from 1st year to 5th year.
Okay.
So,
So we're clear on that, Dr. Palines and Dr. Tan. Okay. Here's a question, a very interesting one. Can PALES endorse surgeons doing endoscopy, flexible endoscopy, to certain hospitals requiring such accreditation? Since we're named or called as Philippine Association of Laparoscopic and Endoscopic Surgeons.
That question is for you, Ray.
So what's the question, Ray? You didn't
Sir,
get
can
the
PALAS
question.
endorse surgeons doing endoscopy, in those certain hospitals that require accreditation for flexible endoscopy? I think
Ray, you're the
maybe
one,
I can,
you're
yeah.
the most, yeah, please answer, Ray, for us. Thank you.
I think maybe, of course, PALAS can endorse. PALAS can endorse surgeons who can do endoscopic surgery or flexible endoscopy as long as they're able to show there is formal training in flexible endoscopy, or endoscopy has been part of their training. For example, a colorectal surgery program, and in that program they have a flexible endoscopy there, and they have a trainer who's well trained or has been trained or has accreditation in flexible endoscopy. Then probably PALAS can certify that surgeon with regards to flexible endoscopy. Endoscopy in the coming years, PALAS will be very active also in incorporating endoscopy in our curriculum or in our surgical in our curriculum in endoscopic and laparoscopic surgery. Then we can certify surgeons who's doing flexible endoscopy. Since in the Asia Pacific region, it's the Asia Pacific Society in Digestive Endoscopy who is the mother society that's answerable to the WEO or World Endoscopic Organization. But the only accredited endoscopic society that ASGE or ASPDG Asia Society is recognized in the Philippines is the PSDE, or the Philippine Society of Digestive Endoscopy. And mainly the membership of that group is our GI colleagues. So for surgeons who would need accreditation or who would need certification that they can do flexible endoscopy, then I think PALAS can help them with regards to this, as long as they show that they are adequately trained and they have the numbers to show or the cases to show.
Thank you, Mr. Moderator, for enlightening us. You can continue now moderating.
Okay. And here's from Dr. Arcilia. Is the face covering exclusive to the PALAS board? Yung mask natin is
And past presidents.
Sir, we already sent you one through Lalamove.
I think this mask can be available for all the members of PALAS.
Kuya, there's one more question. How about for upgrading from associate to fellow? Are there new requirements?
I think Dr. Palines can answer that.
Actually, if you're an associate member, you have 2 years before it expires. So after 2 years, it's either you renew your membership as associate member, or you upgrade your membership to full PALAS fellow. So if you want to be full PALAS fellow, you fulfill the requirements for a PALAS fellow.
Okay. So I think the new requirement would be submitting a new set of videos.
Yes.
Okay.
Yes. Five videos, just like a fellow. So we can just evaluate that video, and that's the only requirement, since you are already pre-screened before.
Okay.
There's another question, Kuya.
Where would you use a certificate of good standing issued by PALAS? Is it required for PRC renewal, or is it a prerequisite for PMA or PCS certificate?
Okay, so actually we're not giving out certificates of good standing. So the one we're telling you is good standing as fellow of PALES. So that's the rights of a fellow. That is one is voting. No? So that's the only one that we can use that. But we do not give PALES certificates of good standing.
Okay, Mon, thank you. Here's a question from Dr. De Vera. Those graduating from non-accredited institution, how can they become a fellow?
So non-accredited institutions usually follow the same process before, where you need to enroll in a basic laparoscopy workshop in PALES. So that's the only way for now to become a fellow. But once you are accredited, your institution is accredited, then there is no problem with that.
Okay, another question from the Q&A box from Dr. Cañones from Rizal Medical Center. A newly graduated MIS fellow, can they use their cases during fellowship for compliance in the requirements?
Yes, no problem. They can use that. The best videos are done within the past 2 years, preferably within the year. If you have 10 cases, 10 assisted and 10 cases.
Okay, Mon. There's a private message from Dr. Filona to me. Pinapagalitan niya ako. He wants to me to come up with a unified fellowship for endoscopy already. We're trying to do that, sir. So in the process po, the curriculum is already in place. Inabot lang po tayo nung COVID lockdown, but during the Bohol workshop with the PALES board, we included endoscopy already in the curriculum.
Yeah, to Dr. Filona, in fairness to Dr. Ray, nagawa na po niya. Nagawa na po. Okay, Ray? So
Okay.
I think we're running out of time.
Okay, so can I give... okay, may pahabol. Sorry, wala na. So are there any last words from Dr. Tan before we close the session? A reminder lang daw, sabi ni Dr. Filona. Think. Hindi naman daw ako pinapagalitan. Okay, so okay, before we close the sessions, any few words from Dr. Tan?
Yeah, thank you everyone for your comments, questions, and inputs. Rest assured that we will be considering this when we do our final admin manual. This will all be incorporated, and we appreciate really your comments so that there will be no more question when we come up with the admin manual. And hopefully we'll finish this before the end of the year. Thank you again for your comments and your presence. Ray?
Okay, Mon?
Okay. Thank you to our panelists. That ends our PALES guideline session. Our next session, okay, let me okay, so our next session is the PALES Zero PDI campaign. All right, so yes, this is me. It is truly a privilege and honor for me to be among the resource persons during this webinar. Good afternoon once again. So to give a brief background on the PALES' humble beginnings, some of you knew that the trend a decade ago was to go abroad for surgical fellowship training. And return as an expert in the field regardless of quality of program and curriculum attended, the duration of training, the actual hands-on exposure or surgical skills training. Nobody can discount nor question anybody's training or skill set. The more, the merrier, as the saying goes. This reminds me of my time as a surgical resident 2 decades ago under the tutelage of one of the pioneers of laparoscopic surgery in the Philippines, Dr. Kim Chi Tan. He gave me the boost and his vote of confidence to learn and master the craft. During the years, I have met kindred spirits who also enjoy the practice of minimally invasive surgery and who are willing to create waves in the surgical community. That time, there was still no governing body to regulate the practice of minimal invasive laparoscopy. Hence, a strategic planning session spearheaded by Dr. Crisostomo Arcilla Jr. was held in 2010 that set down the foundation of PALES now upholds. The society mission vision statements were enumerated, and since then, there has been numerous endeavors to ensure that its mandate is fulfilled. This laid the groundwork to a succession of noteworthy projects, starting with the establishment of the PALES curriculum in 2012 under the leadership of Dr. Vicente Porciuncula. As the curriculum came into fruition, a handbook is needed to complement the curriculum's purpose and is intended to be a technical reference manual in all aspects of basic laparoscopy. Thus, in 2014, when Dr. Maki Failona was the president, the PALES handbook was created. It was a year-long tedious process of conceptualizing, researching, writing, editing, and photo shoots until it was launched successfully during the 2015 4th Annual PALES Convention. The year was also special because Dr. Serafin Hilvano, a foremost pioneer in minimal invasive surgery, graced and witnessed the launching of the handbook. For those who are living under the rock, Dr. Hilvano was the de facto representative of the specialty in international meets, who also opened the gateway for many surgeons to train abroad. These are the These are the individuals who banded together and formed the core group of what is now known as PALES. They would be selfishly devoting time, effort, and knowledge to be the vanguards of endolaparoscopic surgery in the country. Moving towards standardization, PALES started accrediting institutions to ensure that basic knowledge and techniques in laparoscopy are complied with. Now that the basic standards are set for basic laparoscopy, what about advanced MIS? Surgeons wanted more to offer in terms of skill set after getting competent in basic laparoscopy. Hence, a unified MIS council was created to standardize the MIS Advanced Program. During one of our stints in Naga City, we have come up to a realization that despite the teaching and standard techniques in laparoscopy, cholecystectomy, the critical view of safety, there is an anecdotal evidence of the high rates of bile duct injury still persisted. However, there were no hard data to support this. It truly puzzled us. So while stranded in Naga City Airport, waiting for our flight back to Manila, we brainstormed. The concept of introducing an advocacy campaign to combat the problem was born. In those few short hours of waiting, we gave our campaign a title and tagline, created the objectives plus the mission vision statements, planned a newsletter, and even a mascot. PALES as a group also wanted to act and conduct an investigation to establish the real incidence of bile duct injury. Is it lack of knowledge? Is it the technical aspects? Or is it because of the surgeon's prejudice? PALES wanted to answer this. What is the reality of MIS in the Philippines? This serves as the catalyst for the launching of the Zero BDI campaign, which was launched in 2017 under the presidency of Dr. Alex Erasmo. One of the landmark projects of PALES is the Zero BDI campaign. Essentially, this advocacy campaign is directed on documenting the actual incidence of bile duct injuries during laparoscopic cholecystectomy in the country, and eventually identifying the factors that cause such injuries so that recommendations can be made to mitigate this. To date, there is still no data on the actual incidence of bile duct injury in the country. Please watch the video.
This was a tragic situation.
He, meaning Martha, went in for a routine, minimally invasive surgery, was discharged. They hit his intestines. He was taken to the hospital 2 days later. And as we all know by now, he was in intensive care where he stayed until he died.
This doctor cut the duct, the wrong duct, and there was bile spewing into his stomach. And bile is very acidic, so it was causing an irritation in the stomach.
Okay, I give you now to Dr. Miguel Mendoza.
Thank you very much, Mon, for that beautiful presentation about the evolution of PALES through the years in the last decade. Since the launch of this PALES-led initiative, the Zero Bile Duct Injury Committee members have already accrued miles in scoring almost the entire nation in promoting safe laparoscopic cholecystectomy. Despite its toll on the members' family time, academic works, various professional society responsibilities, and clinical practice, we were graciously welcomed with open arms by our colleagues in all the ports, cities, and municipalities of the Philippines, which we have visited. As you can see, it also took its toll on our bellies. We probably gained at least 20 pounds over those 3 years. 3 years, 3 members, and 23 cities on, it is now time to evaluate if the seeds we have planted have been effective in reducing the bile duct injuries in the country. A survey will be posted as a link in your chat box. Rest assured that you and the information you will provide will be kept in strict confidentiality by the main researcher and the advisor only. Hence, we are imploring your utmost honesty in answering the form. Whatever the result of this study may be, the data will ultimately help us in determining the need for a prospective study that will identify factors resulting to bile duct injuries. We encourage all general surgeons performing laparoscopic cholecystectomy, including our senior residents, to join the survey. Thank you very much. Before President Duterte announced the lockdown, we already held the first virtual Zero BDI campaign in Tuguegarao. I guess this was done on March 12, 2020. We were supposed to travel to Tuguegarao, but apparently there was a lockdown coming in and we decided to postpone it. This was our first encounter with a Zoom meeting with our participants. I guess Lady Luck was on our side because we were supposed to go to Tuguegarao to usher in another full year of activities. As you can see from the map, we have put location tags on the regions we have already visited. Thank you.
Thank you, Dr. Ike. So, did we achieve our goal 3 years after launching the Zero BDI campaign? To all the general surgeons in the country performing laparoscopic cholecystectomy, all senior GS residents, please answer the this questionnaire later. It's time to make a change. Let us hear your voice. The link will be posted in your chat boxes. Let me give the floor now to the people who are the key individuals to prepare the society for what it is now. They are very well known to everyone. Our first speaker was the palace president in 2013-2014. Please welcome Dr. Maki Failona.
Thank you, Mon. So my task was to give some form of introduction to the phases of PALES as we achieve what Mon mentioned, the standardization of the curriculum. As Mon mentioned, it actually all started during the term of Dr. Jojo Arcilla when he formulated the possibility of coming out with an online module for learning laparoscopic surgery. At the same time, during those periods, we have been accrediting institutions already as to the training of basic laparoscopy for the residents. So through those years, even during the term of Dr. Enteng Porciuncola, we actually started to push having a standardized curriculum because the number of training institutions being accredited is growing. So we wanted that all of these accredited training institutions have its unified curriculum so that the training of laparoscopic surgery in the Philippines would be unified. So as a born out of those efforts, the standardized curriculum was created, and eventually the PALES manual, which was all written by local authors. So after we have stabilized or standardized the curriculum for the residents, before I ended my term, I actually asked Mon, Jeff Domino, and Ike Mendoza to come up with the unified MIS fellowship program. And the basic reason for that is that we know that soon enough, MIS fellowship programs will sprout from the different parts of the world, of the country rather, and it would be proper that this curriculum should come from PALES. And that's what happened now. You have your MIS Council, and probably the last assignment, as I was pushing Ray earlier, is to come up with the unified endoscopy fellowship. So I think that's all that I have to say about the curriculum.
Okay, thank you, Sir Maki. Our next speaker to talk about the campaign is Dr. Alex Erasmo, our immediate past PALES president. Dr. Erasmo, please.
Thank you, Dr. Raymond Ong, one of the energetic and movers of the association. The association is in good hands because of people like him. Since the introduction of laparoscopic cholecystectomy in the 1980s and in the United States and Europe, and in the 1990s in the Philippines, there has been an alarming and significant increase in bile duct injuries. In a landmark publication in 1995 by Dr. Steven Strasberg, data from 7 large studies of over 8,000 laparoscopic cholecystectomies, serious complications occurred in 2.6% of the total population. A combined review of 8 large studies of lap cholecystectomy reported the incidence of bile duct injury of 0.26 to 0.6%. Looking at the absolute numbers, we might be misled and we might misconstrue that it is very low. But if you look at the number of laparoscopic cholecystectomies performed globally every year, the number of bile duct injuries are staggering. In the United States alone, around 750,000 laparoscopic cholecystectomies are performed annually. So if you get the 0.26 to 0.6 bile duct injury, that will amount to around 1,950 to 4,500 cases of bile duct injuries in the United States alone. The incidence, if you compare that to open cholecystectomy, is around 3 to 4 times higher. And that is the reason why when we started the laparoscopic cholecystectomy in the Philippines, there were a lot of hesitation to adopt the procedure because of the technical difficulty, the learning curve, and the data that came out as far as incidence of bile duct injury is concerned. Several factors come into play: the diagnosis, the disease entity, variations in the anatomy, and also very important is the surgeon's experience. A report of over 8,800 laparoscopic cholecystectomies performed by 55 surgeons estimated that 90% of bile duct injuries occurred in the first 30 cases for each surgeon, with the incidence dropping from 1.7% in the first case to 0.17% at the 50th case. Let me emphasize that at the 50th case, 50. And that's how steep sometimes the learning curve is. In the Philippines, unfortunately, as was emphasized by Dr. Ong, we don't have the exact numbers as far as the incidence of bile duct injuries. And that's why during my term, I initiated a study that will look at the database of bile duct injuries in the Philippines. We were already in the initial phase of starting the study, but we had to cancel because at the time we were preparing for the ELSA Congress in Cebu City, and we were concerned with the financial aspect of the ELSA Congress. But right now, I suppose that it is imperative that PALES, as the leading organization in laparoscopic surgery, should take now the challenge and come up with a database as far as the incidence of laparoscopic cholecystectomy, of bile duct injuries in laparoscopic cholecystectomies, and the survey that is now being initiated by the board of directors are very much welcome. And the advocacy on the zero bile duct injury and campaign by the leadership of PALES, particularly these three guys who initiated that. Actually, I didn't tell them to do it. They initiated that among themselves, and I admire them for that. Ike Mendoza, Bon Ong, Juvi Villaflor, these were the people who went around the country promoting safe laparoscopic cholecystectomy technique. And right now, hopefully, it has gained ground and hopefully has improved the performance, the safety of performance of laparoscopic cholecystectomy. And right now, PALES is conducting regular training and workshops to improve proficiency in laparoscopic procedures. Fellowship programs that are being established nationwide will definitely improve the technique of performing laparoscopic cholecystectomy. Likewise, I would like to probably recommend to PALES and to PSGS that the number of requirements for eligibility of a graduating general surgery resident as far as laparoscopic cholecystectomy should be increased because of the minimum number of cases that will come up with a safe laparoscopic surgeon. With the present pandemic, I know this is difficult. Some hospitals, some surgeons are hesitant to perform laparoscopic procedures because of the risk of the transmission of the virus. But as things will improve, as the conditions will improve, I think we really have to increase the number of cases required for our graduating residents. So I would like to thank the board of directors of the association for coming up with all these programs and we fully support. And I would like also to get all the support of the training departments, training hospitals, all the chairs and hospital managers to support this campaign on zero bile duct injury. Thank you for the privilege of addressing this audience.
Thank you, Dr. Erasmo. So to complete the trio is Professor Jojo Arcilla, the man who envisioned the standardization 10 years ago. He will talk on bile duct injury, its impact on quality of life. Please welcome Dr. Crisostomo Arcilla Jr. Sir.
Hi, Mon. Good afternoon, everybody. Is my mic okay?
Yes, sir. Thank you.
Sorry, I'm in the office. I'm at work right now in GH, so I have to conduct this session. Am I coming in loud and clear? I can send all the secretaries out para hindi na ako mag-mask.
It's okay, sir. It's loud and clear.
It's okay?
It's loud and clear.
Okay. So before I go on with my slides, pwede naman mag-share ng screen?
Yes po. Yes.
Put my first slide on.
Jeff, do you have the slides of Dr. Arcilla? Thank you.
Okay, thank you. Anyway, before I start, let me congratulate first the president, current president of PALES, Dr. Boy Tan, my idol. And since this is the 10th annual convention, it's so proper. Ang president, President Tan, 10, no? Okay yon. Sounds good to me. And then I wanted to also insert yung question ni Dr. Ong earlier regarding did we achieve PALES BDI 2020? If I were to answer that now, I would tell you, of course you did. Nobody actually predicted the pandemic. But when it struck and we were all placed on ECQ, wala na nag-opera. Right? Maybe even in the entire country. So I would presuppose, or I will assume, kung wala nag-opera, wala ring injury. And this is happening now in 2020. So you did achieve it. Okay? Your vision na zero bile duct injury in 2020. But in fact, now that I see how the whole program went, from the time that Alex Erasmo initiated this advocacy, you actually planted the seeds amongst all the 23 courses that you conducted. And you were able to lay down the groundwork, the standards of care, and techniques. So meaning, ito ngayong 2020, fast forward to the present, is the start of zero bile duct injury. Meaning, as we start this year, since the framework, the groundwork has been set, or the foundation has been set, dapat from now on, we have to make sure that we will be true to this calling, this advocacy. Dapat wala nang makaka-injure ng bile duct. See, because my topic at hand right now is just to share with you a recent paper that we published internationally, the effect on the quality or impact on the quality of life of the patients who underwent reoperation after obtaining the bile duct injury. So, okay, so this is a journal recently published this year. We submitted it for publication in the International Journal of Hepatobiliary and Pancreatic Diseases. With me are Dr. Zamora, the former Chief President of Manila Doctors, and Dr. Perez, who helped me format this actual paper for submission to this peer-reviewed journal. So it was published just this year, February 11, 2020. So Can you move forward, please? Slide. Can you give me control, Ike? I mean, Jeff? Or kayo na lang? I don't have control. But anyway.
Kami na po, Doc.
So I can control it. Okay, thank you. Wala, I cannot.
Kami po yung magko-control, Doc. Just say next slide po.
All right, thank you. Okay, so this is the title of the paper, The Quality of Life After Repair of Iatrogenic BDI, post-cholecystectomy in Filipino patients. Okay, next slide, please. Can you see my cursor, my arrow? Nakikita ba yan?
Hindi po, Doc.
That's why. You cannot pass it on to me.
Kayo po yung mag-share kung meron po kayong
Baka mawala yung connection ko. It's okay. Never mind. Anyway, on this particular slide, I just have to emphasize to everybody that there have been previous papers regarding review of the quality of life in patients who have sustained injuries post-laparoscopic cholecystectomy. And if you see on this particular slide, there are actually health-related issues, especially mental health concerns among their patients even after they were well and alive post-injury and have recovered from their affliction. There's still more of the mental, psychological, and emotional aspects in recovery, which never went back to normal. Okay. There are also some studies which show, in the second paragraph, with Carbonen and Hogan, that there's actually no difference 5 or 8 years onwards after repair from their injuries. Okay, next slide, please. Okay, so the format of the study was to try to get as much population to give it more power, but unfortunately, out of the 63 BDI patients, we were only able to contact 45. Those underwent hepatico-jejunostomy for repair, and only 22 were full responders, meaning we sent them questionnaires, both in English and Tagalog, all over the country, and the complete responders are only 22. So we could only include these 22 patients in group 1 as the study group. And then, mind you, all of these patients are only operated on by one surgeon. So there's no variability in the surgeon factor. The other 22 patients who were closely matched with regard to age and gender were also performed by the same surgeon so that there will be a comparative data or control. This is a cross-sectional observational study done over 20-21 year period. Next slide, please. Next slide. Okay, so we used the tool, the short form or the SF36 RAND Health Survey Questionnaire, self-administered, and considering the following domains of limitation in physical activity, emotional, mental, bodily pain, and so on down the line. Okay, so these were both converted into English and Tagalog survey questionnaires, which were validated and approved by the IRB of the hospital. Next slide, please. So demographics here, just to show you comparatively that the BDI patients, about 10 males responded in full and 12 females, a total of 22, and the median follow-up of about 72 months or about 6 years. And for the normal post-op patients, those who underwent lap chole and closely matched, there's no significant differences. Next slide, please. Okay, so we'll just go on to the meat of this table. You see the 8 domains, which are very important in the RAND 36 quality of life assessment. And can you click one, please, forward? Yeah. So to highlight amongst all of these, only the first 2, physical functioning and role limitations due to physical health, were noted to be significant, statistically significant. Although, in terms of emotional and mental well-being, Though it is not statistically significant, I would not say there is trending, but it was clinically significant in the responses of these people. So much so that there is sometimes a correlation between not only the physical aspect, but the mental as well. But of course, if we're going to be strict about the evidence, only the first two on the physical aspects will be significant. Next slide, please. Okay, click one more, please. So this is just my favorite slide always that I show, just to give a highlight of comparing both groups. A patient who goes home the same day or next day after an uneventful lap cole, and someone who will undergo surgery 5 times and 4 procedures and still end up with tubes in place such as this. So it's a no-brainer, actually. The emotional, mental, psychological, plus the physical aspects will really be significantly different between the two groups. Next slide. All right, so why is it that probably the mental aspect did not, as shown in the international literature, did not approach the same level of significance? Well, it's probably because this is just my observations. Perhaps, as some of the patients intimated to us, the strong family ties and support after the injuries and when they were recovering was a big factor in their actually getting over the hump, so to speak. Meaning it was just the physical activity that was compromised. They felt that they could not go back to normalcy, especially the young ones, but at least mentally and emotionally, they were able to recover. Next slide. See, in the international literature, if I may borrow that slide again, the mental health concerns were more commonplace. But then again, when you read between the lines in these papers, they say that most of those who had mental depression and emotional depression were those who went to court or filed malpractice suits against their surgeons. And especially if the cases dragged on for months or even years before they get total or no compensation at all, then even if physically they're okay, mentally and emotionally, they are depressed for the rest of their lives. Next slide, please. Okay, so in conclusion, so far we really try to look for a search of literature locally or nationally, and we have not seen any other health-related QOL regarding bile duct injury recovery in patients post laparoscopy. So this is probably the first paper. It's a small sample size, I admit, and that is a very big limitation to this study. But then again, it is a springboard by which we can now use as a benchmark in trying to find out if this is going to be a norm across the board for all patients who will, from now on, hopefully, wala na sana. If meron man, we have to watch out for those health issues if ever a patient sustains such an affliction. Next slide, please. So I wanted to show this slide. Yung Focals team ito no? When I was with them in one of the missions, I think Simon, the whole force was there, Juvie, Mon, Ike, and then Ray Sarmiento, and I was invited to that mission, and all the Focals team. And I'm really so grateful for making me a part of that activity. And this is what I mean by family. Yung sinasabing support ng family dun sa, hindi lang yung family sa bahay. But if you have a team like this, you don't even have to talk about bile duct injury. And they will always support the patient. And mind you, pro bono lahat ito. They did this 22, 23 na ba? At least yung 23, siguro kung 23 virtual yon, Ray, siguro meron din virtual bile duct injury, no? At least pwede ma-reverse yon. At yung bile duct injury virtual. No harm, no foul. Okay, next slide, please. This is the team with the beautiful nurses there. And that's us. And really, it's a very happy occasion there in Palawan. Next slide, please. So now, on my final slide, or my thank you slide, I thank the board, especially the three, yung Trio Los Bobos na nagpasamuno nito. No? Kasama ka na dyan, Ray. This scrub suit, whenever I wear it, I make sure it's a lap cole case. Because people will ask me, ano ba yan? And then I start talking about it. See? And it also reminds me that yung intraoperative timeout and the CVS, it gives you a reminder on what it's all about. So this advocacy now in 2020, which should be the title of this talk right now, onwards, your strategies should be well placed. I don't think, Mon, you're there, no? Yung tinatanong mo kanina earlier, I think I mentioned it before, that the way to go is to start by institution, yung reporting, from now on, and then by chapter, and then you move to the non-accredited institutions, and then nationally. Because if you go national immediately as a strategy, there's a tendency for people not only to hide, but to, publish their results, and it's going to be very hard. So you really have to brainstorm again, so that from now on, onwards, from 2020, ang target nyo, this will be the start. Since you lay down the framework or the groundwork, dapat wala nang may injure na pasyente. At least in all the accredited institutions, in all the chapters that are involved, all 19 chapters, and maybe those who are doing it in other smaller hospitals, na hopefully you can attract them to follow the standards that this advocacy has set forth during the time of Alex Erasmo. Okay, with that, I'd like to congratulate again and thank the committee, the board, for a very good presentation. Thank you very much.
Thank you, Dr. Arcilia. That was indeed an excellent talk. I hope we really go to a zero bile duct injury from now on. So I'd like you now to check on your chat boxes. Dr. Arcilia, I think that will be the baseline data of our bile duct injuries performed by general surgeons in the country. So please check the link in your chat boxes and take this time to answer this survey. All general surgeons performing laparoscopic cholecystectomy, whether you are PALES or non-PALES member, as long as you're doing the procedure, please click on the link and take this time to answer the survey. Do you have the link? Great. So all of us present today, please click the link and answer the survey.
Okay, Mon?
Yes, Ray.
Okay, so we have 317 participants logged into this virtual Congress. Thank you, Dr. Arcilia, for that very enlightening and very excellent presentation.
Yeah, maybe you can entertain questions, Kuya Ray.
Yes, we'd like to entertain questions. You can post it in the chat box or in the Q&A box. So far, wala pa. Any questions from our past presidents? Dr. Filona, Dr. Erasmo, Dr.
May I comment, Ray?
Yes, sir.
Either they did not understand anything I said, o malinaw.
Malinaw, sir.
Clear, sir. It's clear.
Wala nakintindi, o kaya walang question eh. Okay. But I'm open to questions. You can privately message me if you like.
Okay, I think Jeff opened his mic. Jeff, do you have any question?
I just want to say it was very clear. Thank you to Dr. Arcilia.
Open mo yun.
Okay.
Yung link natin.
Dr.
Email ko.
I'll pass on the mic to Dr. Filona. Sir?
What about? No comment, Ray.
No comments, okay.
Yeah.
Malinaw talaga, sir. Wala pang nagpo-post ng questions. Maybe we have Cathy here, who is our Madam Prexy in PAPSI. She would also like to initiate a zero BDI campaign in the Society of Hepatobiliary Surgeons, and maybe she would like to tell you or discuss plans with regards to PALES and PAPSI joining together or collaborating efforts with regards to zero BDI campaign. Kathy?
Thank you, Ray. Um, good afternoon, everyone. Thank you, Dr. Arcelia, for that very enlightening, excellent talk. And it would really be an honor if we would have a collaboration between different centers to put in together our patients who we repair for their bile duct injuries and know where we really are in the country. We do have several centers that are becoming like sort of a referral center, no? And it is our task, especially in the PAHPBS, to look after the welfare of these patients who have had bile duct injury. So we would like to take a proactive approach together with PALES to promote BDI, zero BDI, para hindi na makarating sa HPB yung bile duct injury repair. I'm sure Dr. Arcelia will be very much agreeable with that. And that is something that we do hope, because we see patients with really poor quality of life, and to the extent of a couple of them who had to undergo liver transplant. And that is really very, very sad. Something that we truly don't want to see. No? So with that, I would like again to congratulate the board and everyone else, especially the three gentlemen who has been very active, and I'm very thankful to be part of this as well in the past year, in the campaign, in our trips and live surgeries. So that was truly, like Dr. Arcelia said, family, sense of belonging, sense of being part for a good cause. And we should all be very proud of doing this and continue on to promote the advocacy of zero bile duct injury. And if we will be able to, or we will see any bile duct injury, we do hope that they can be referred properly to the proper center, so that patients will not have to undergo 5 surgeries, 6, 7, 8 surgeries to avoid a very, very poor quality of life and shortening of their lifespan. It is we should be very responsible in thinking about the patient's welfare instead of pushing for a repair, even if we're not ready to repair the patient. So that should be a responsibility of all of us. So thank you again for this opportunity to promote the advocacy. And we are here from the PAHPBS. I'm representing both PALES and PAHPBS, and hoping that we push this zero BDI to fruition and to proper repair of bile duct injury. Thank you.
Thank you, Madam Prexy. Very
I
inspiring.
react to Kathy's comments. Kathy, those are very, very good comments. Actually, it's not part of my talk. That's why I never brought up any of those issues. Then again, you will notice in this paper, all of these cases are personal cases. We do not include the service cases and the charity patients we did in our institution, merely because long-term follow-up is not possible. For the information of everybody in this audience right now, the follow-up of these patients will not be 6 months, 1 year, or 2 years. It has to be 5, 10 years, with a median follow-up of at least 5 to 6 years, or even 10 years if possible. And if you have charity patients or patients who are service patients, it's virtually impossible for an institution to follow them up. And this is what up by Kathy. It's not the beauty of the repair, mind you. It's the success of the repair after 3 to 5 years. They're still giving you QOL, or quality of life scores, after 5 years, which is very acceptable and near the values that we have for the normal lap chole patients, then we would have achieved our goal. But then again, it's not about beauty of repair or expertise of invention. The issue at hand is zero bile duct injury, so it's not pure. BDI should not have the expert doing the cure. It should be everybody doing their part, wearing face masks to prevent spread of the pandemic. And the same thing, which is being advocated here, everybody should follow the standard 4 ports that is being advocated by PALES. So out all of those 23 circuit courses, pro bono, by sacrifice, demonstrating, lecturing over and over again, okay, you prevent the injury. Then we can flatten the curve. Thank you.
Thank you, sir. Before there's a question in the Q&A box, but before I pose a question, may I remind everybody to mute their mics. There's some feedback. So, Dr. Arcilia, there's a question in the Q&A box. Once an injury is identified, how do you, probably this, how do you approach the patient or the relatives? Is there a standard way to do it, or you deal with it accordingly to the presentation or the presentation of the relatives or the patient himself or herself?
I think that's a PM question, isn't it?
No, sir, it's in the Q&A box.
Kathy, I'll tell you this. Each and every patient, the 63 patients that I talked about, I asked them how was it explained to them and all that. But even before you ask that question, I call the surgeon first. Okay, so you will know, okay, what to tell them when they try to start asking you about an explanation. Now, I think the question is about what if you were the one, right? If you were the one who actually incurred the injury. Okay, so iba-iba eh. Actually, I did not, ballpark figure, siguro mga 70% of those that I encountered, nagtapat naman yung surgeon. Nagsabi that inadvertently, like this and like that. Of course, some had issues like aberrant anatomy and all that. But then again, pag nakinig kayo sa mga benchmark techniques na ginagawa ng itong zero bile duct injury na yon, even an aberrant anatomy can be avoided in terms of injury if you follow strictly the guidelines that have been set forth, no? But different folks, different strokes. Iba-iba yung mga sagot dyan. Sorry, I cannot be on a personal level on this because knock on wood, fortunately, I don't have, for the past 30 years, have to explain to a patient why it occurred. I can only relate to you others who have told me why it happened to them. But parang hindi tama sa forum na ito eh. I mean, in open forum, if I say that, whoever posted a question and those who want to, I can talk to you privately, but not in open forum. Unless Kathy, in your personal experience, how would you answer that? I really try to answer these questions privately. Kathy?
Same doc. I try to talk to the physician, to the surgeon, and I try to ask for the report, the operative report, because some of them, I'm sure you would have encountered, some of them actually didn't realize that they injured the bile duct. Some have come as a late discovery, so not every surgeon knows. Some of them come as a surprise. Whether it is real surprise or a pretend surprise, we don't know. But the fact remains that the most prudent is to ask the surgeon. At least they are aware, and also the patient knows that we took an effort to understand what actually happened, and we don't jump into conclusion. There are several aspects, many things that need to be considered, as you've said, anomalies, anatomical variations, and this can all be attributed to the cause of injury. And perhaps I should say, I would say that it can happen to any one of us. We cannot, we can't say we are immune to it. It can happen to any one of us. And that's the reason why we have to be very, very cautious and we have to be extra careful. And the truth is that the more we see the bile duct injury, the more cautious, the more meticulous, the more paranoid we are when we're doing the cases. So I can say personally that apart from seeking the explanation or the view of the surgeon, there are times that many of them really would not know, and some have deliberately, there are a few who deliberately do not admit to it. And these are the cases that have gone to the court, for which we have to serve as a witness, which is very, very difficult, very challenging for us, because we don't want to put them in that situation. And we don't want to be going to talk about all these things towards another surgeon, right? So it is very, very difficult to be involved in a bile duct injury. So we really hope that it doesn't happen anymore.
Yep, exactly. As a follow-up to that, Kathy, if I may, Ray.
Yes, sir.
Okay, I will just react again. I will just add, actually, I have stopped. In the first 10 years, I make it a point to get the operative technique and probably the video, if this is possible, because I tell the surgeon that it will help me in trying to navigate my way through this. And so I understand. But with all the imaging possibilities now, especially MRI, MRCP, I stopped doing it because I recognize that more and more litigations are coming up. Okay? And the more you hold evidences against the surgeon, the more you will be subpoenaed for this. And it happened to me in one particular case when they could not get it from the surgeon, but they found out that I was holding the video, a copy of the video, and it can be subpoenaed actually. Okay, but rest assured, whenever like Kathy or myself, we cannot speculate on what happened during the first surgery. I always say that. Okay, if they ask you, no, I will not, because I wasn't there. Meaning, you were not at the scene of, sa police yan, SOCO, scene of the crime. Yun ang actual evidence. They're just asking you for your opinion, which is not good. I can just tell them, when I opened up, I saw the proximal bile duct, usually fibrotic na yung kung saan man ang injury. I do not touch it anymore because it's not part of the repair. I just go high up and repair in normal tissue. So I will not conclude anything by saying, ay, ito yung naputol niya dito, because there's no evidence of that. Everything is fibrosed. So I will just tell you objectively in the court that this is what I saw. So do not make me speculate, otherwise I will just shut my mouth. That's all. So this is for everybody to know, not to protect you, but then again, to tell you we shouldn't get to that point.
Yes.
Not the cure. Again, dito, an ounce of prevention is better than a pound of... Talagang ito yung, that saying really should stick from now on. Ounce of prevention, okay? If there's an elephant in the room, then we have to address it. Nobody should ignore this anymore. Mahirap talaga gawin yan. Yung mga nata-transplant, ano, Kathy? In the States, routine. Those who are really hopeless and ano, they will end up on transplant, and for ano na yan, lifetime immunosuppression and all that, kawawa naman. For what you said, simple cholecystectomy. Right? So it's unforgivable.
Okay.
And it's actually not only transplant, because these patients whom we follow up for a longer period of time, now a couple of them have developed cancer. So this is again another complication from another complication. So it is something that we really want to prevent, and we don't want to come to that situation.
Okay. For that, Dr. Arcelia and Kathy, let me backtrack a little bit. Maybe it's not a question would be not how you approach the patient or the relatives of the patient. Sir, very standard in our Zero BDI campaign would be the question is, what if I am a very young laparoscopic surgeon doing a laparoscopic cholecystectomy, and then I realize that I injured the bile duct? What will be the conduct of my surgery or my activity after identifying that bile duct injury, and I know I am not prepared to repair that bile duct injury?
That for me?
Yes, sir. For you, Kathy, and the rest of the panel, probably.
Personally, yeah, if this is and it happens to you, make sure you're not doing it in the middle of the night. All right?
Yes, sir.
Because ang hirap talaga magtawag. But this is the time that you think about the patient. All right? And you have to swallow your pride so that pag natapos ang problema right there and then it's just mitigating everything after that. But if you do not correct the problem immediately, that creates more complications for the patient and the family. So, yung mga napasukan pa intraoperatively, more or less, after a few months, it dies down and everything is settled and okay lang. Ang mahirap, yung nga sabi ni Kathy, those who do not recognize the injury, because in the US, if you miss it during lap and patient comes back with an acute abdomen, jaundice, and all that, that is outright evidence. Res ipsa loquitur. Para sa kanila, outright settlement yon. Wala nang court yon. I-settle na yan because the patient was previously well, elective yan, tapos bumalik ganun. Ano na yan? Wala, hindi na pumupunta sa korte. Settle na yung mga issues niya.
Okay, sir. Before I let...
In addition to what Dr. Arcilia mentioned, if such case happens, well, we hope it doesn't happen, but I think even prior to every surgery, every lap chole or any surgery for that matter, it is very important to explain and have established that rapport with the patient and the family. And immediately once something happens, we have to tell them what exactly happened. If you cut the bile duct, you cut the bile duct. It is important to be upfront rather than hide the truth and then to be realized later by another surgeon or by an imaging, and then that will be a domino effect. It will be even more difficult to handle. I think when you have a very good rapport with the patient and you have established that from the very beginning and you have offered a solution, for example, a referral, of course, as Dr. Arcilia mentioned, wag naman sa gabi. So hopefully, I think it should be something that we consider. Never do any elective surgeries in the middle of the night, or much more, don't do any acute surgery once when you have finished a whole day of long surgery when you're already tired, because it's very certain that you're not going to do a good job. So that being very cautious about that, being aware of the situation, the situational awareness is one crucial factor. So when something like that, an injury has happened, talk to the patient, talk to the family, and offer a solution. There would always be somebody there who will be happy to help you to repair, to at least temporize the procedure, and then take it from there.
Okay, Kathy and sir. So I think the bottom line is don't monkey around if you're not prepared to do the repair. There are two hands being raised, Dr. Don Rosello and Dr. Juvie. But before I pass on, the questions to Dr. Juvie, I'll ask a question first to Dr. Don Rosello before you ask a question. One of the persons were after a bile duct injury, one of the persons that patient who had bile duct injury initially would touch base would be the endoscopist, because they'll present sometimes with jaundice or Don, before you pose your question, can you answer how do you deal with patients coming in with potential or most likely a bile duct injury patient as a surgical endoscopist?
First of all, thank you, Dr. Arcilia, for the great talk. when I approach patients, I tell them with all honesty what I think. I don't try to hide anything. I've had my shares of bile duct injuries. Probably I've had 4 bile duct injuries from a laparoscopic cholecystectomy, starting as early as 2005, and one more recent, which you will see in a video. And I've had my share. I've had my share of repairs. I've probably done between 15 to 20 repairs done by other surgeons, all done open. And what I learned from my mentor before, which is he always told me that you have to be very honest with your patient. If you feel like you've injured a bile duct, then tell the patient that you've injured a bile duct. If I see a patient that has a bile duct injury and it was done by another surgeon, I would try to tell the patient with all honesty that you have a bile duct injury. But we have to be very careful because we don't want to say anything negative. We would always try to tell the patient that your surgeon has done his best or her best. The surgeon has all the best intentions for you, and you have to let the patient come down, let them understand, because there's no doctor who wants to do damage for the patient. No matter if, I've had referrals from surgeons who've had, 3 bile duct injuries and I've repaired all 3 of them. And still, you have to tell the patient, there's no doctor who wants anything bad which would happen to the patient. But then if we're lucky, it's just a Strasberg A which can be repaired or which can be fixed with a stent. That's not a problem. But the more difficult repairs, it will entail a lot of cost. It will entail a lot of and repeat surgeries. And fortunately, most of the referrals that I had, wherein I had to do open surgery, I was able to do, except for one. I guess Ray knows about this because I referred the patient to him, because the bile duct was just, we couldn't even see it when we opened up the patient. We tried to do an anastomosis and there was a stricture and, tried to extend a stent all the way up. But I would like to ask Dr. Arcilla and Dr. Cafite on what their views are with regards to the repair. Because personally, when I repair something, I always try to put a what we call as a chimney, or I try to put a loop of the Roux-en-Y and let it go in superficially, because we know that there's always that possibility that we might have to go back in. And I've had a referral of a patient which was actually performed in UPPGH, and we're fortunate enough to have a chimney. And this patient, I've had to access the chimney twice already. The first repair was done. It was actually for this one's not really a bile duct injury. It's a choledochal cyst. And there was a Roux-Y, but there was no chimney initially. Then I had to redo. Then this time I created a chimney. And that chimney has been very helpful because we've accessed it twice already to do a dilatation and remove the intrahepatic stones, which the patient always manages to develop. I'm fortunate enough that the patients I've had, even as early as 2005, still follow up with me. And even if I placed a chimney on that patient, on her, I haven't had to use the chimney. But what would your opinions be with regards to creating a chimney?
Okay, Don. Pasagot ko lang yung, I'll let Dr. Arcilla answer your question. And then may nag-raise hand si Dr. Jui. But we still have a long program as mentioned by Dr. Mon Ong.
Sige lang, sagutin mo lang, Don. At patuloy mo na si Don.
Papasok ko muna kay Dr. Arcilla. Let Dr. Arcilla answer the question of Dr. Rosello.
Okay, Don. Hi, Don. How's Cebu?
Okay lang po. Maraming kaso. Naglindol pa kayo na umaga.
Nag-duty?
May ano po.
High risk pa ba? Hindi ka nag-duty?
Kaka-result nakuha ko yung result ko the other day. Nag-swab.
Okay.
Pero may exposure na naman.
Okay. Anyway, your question regarding, I have 2 issues to answer now. Especially when we get patients with the injury, right? So if we were not the ones who actually caused the injury in our institution, we refrain from using that term injury. Again, going back to the earlier issue I said, we were not there during the time of affliction or the injury, so to speak, no? So it's not up to the second, third, or fourth surgeon who gets the patient to say that the first surgeon injured. Because in court, once you use that in the chart and label it as injury, then you have to defend that. Bakit mo tinawag na injury? It will just be a presumption na na-injure niya kaya na ganito. So, even our residents will place down, pag nag-jaundice yan, there's a biliary stricture, status post laparoscopic cholecystectomy. So that's without incriminating the first surgeon. Kung may bile peritonitis, sabihin mo, there's bile peritonitis secondary to biliary fistula. So you don't know why it happened. Pwedeng nag-slip yung cystic duct, hindi naman not necessarily na-injure yung bile duct, all of these things, no? This is just to protect, actually, the first surgeon if you are not the one who inadvertently caused the injury. Now, ibang issue yon pag ikaw talaga. As you're saying, Don, you've had it before and you had to be honest about it, that's okay. But for the other surgeons, we cannot, especially in the court of law, answer for them for what happened. You can just tell them what you received the patient objectively on condition like obstructive jaundice or with biliary fistula from a tube sticking out of the abdomen. Okay, regarding the chimney, we also stopped doing this because whenever we do a repair now, it's a hepquinol. I think Kathy knows this. We go all the way up because the injuries will usually be high hepatic duct or even transection of the whole hepatic duct. So our anastomosis will always be up there unless it's really a severe Strasbourg 4A and maybe higher. We always do it from left to right with a lateral extension into the left hepatic duct. And this will not cause strictures, mind you. As long as meron ka pang hepatic duct confluence, it will not stricture because that's a very wide anastomosis. So there's no need to put a chimney or a hepaticojejunostomy limb or the rule limb, the defunctionalized limb on the subcutaneous tissue. Even for choledochal cyst na nag-stricture yung anastomosis. You know, even for choledochal cyst, we stopped doing this. You repair all the way to the top, excise the whole cyst. No, we don't do that anymore. You just maintain a cuff before the actual confluence and excise part of the cyst, maybe 3/4. Hopefully, hindi naman magmamalignancy yung ititira mong cyst doon. Rather than end up with multiple repairs after a choledochal cyst. So that's my answer to that chimney. No? Ang nangyayari sa chimney na yan, the patient is still cursed for life. You will have repeated, like through a tube and all that, they will keep on coming back and the quality of life is miserable. Right? For every repair or reconstruction you're gonna do, your objective is to end it right there and then. Either mamatay na yung pasyente, go all out, or he will be cured permanently. So, pag hindi nyo kayang gawin talaga, i-refer nyo nila kay Kathy o kay Don Roselio. Okay? Ako, retiring na ako eh. Do not refer to PGH anymore. Alright? Pero, i-repair nyo na ng tama, tawagin nyo na yung tamang tao para tapos na ang buhay ng tao. Quality of life will still be for a 30-year-old or a 25-year-old na injured will just be like somebody who had an uneventful laparoscopic cholecystectomy. I think that's a message I want to impart right now. Thank you.
Okay, sir. Thank you very much. Before Dr. Mon.
Yes, hello.
Mon.
Thank you, Doc.
Ray?
Yes, Ray.
Ano?
We can actually answer those questions during the open forum for the
Dr. Julie, baka pwedeng can you pose a question later after ituloy lang ni Dr. Mon yung program and then
okay.
Your question.
All right.
Okay.
Okay, thank you everyone for those inputs. They are very important really, but we need to proceed with our program. Our next speaker is very well known to everyone, Dr. Papi Miguel Rosa, who will speak on achieving the CBS. Okay, Dr. Mendoza.
Thank you, Papi Mon, Dr. Mon Ong. Thank you very much. And I truly enjoyed that session, the last session, and with all the experiences, the insights, as well as the recommendations that were given. It's truly very relevant as far as the campaign of the Palace Zero BDI campaign is concerned. And we really admire people who share their experiences as well as be involved in this advocacy that we have in PADES. And I would like to thank all of you for joining us today. And I probably have heard about this lecture many times in the past. But like any lecture in Zero BDI campaign, what I realized through the last 3 years is every time we have a session like this, I learn something new every day, no? Every time, from the experiences shared by all our experts, all our mentors about this particular topic. So this topic that was assigned to me for today is a topic on how do we prevent bile duct injury by achieving the critical view of safety, which we would like to standardize and advocate in the training of our surgeons, especially our younger residents, our younger colleagues. I have nothing to disclose at this time. And as mentioned and emphasized in the talks given by Dr. Arcilia, especially in his paper that was recently published, that we fear one complication when we do laparoscopic cholecystectomy, and that is bile duct injury. As a surgeon, this is what we fear. And the main reason why we fear this, because there are a lot of complications related to this as well for the patient. It has been emphasized and overemphasized through the discussions of Dr. Arcilia and Dr. Cathy Te and Dr. Don Roselio, as you heard a while ago, that these patients become biliary cripples as a result of this injury. And some even needing, as mentioned a while ago, a liver transplant to handle these patients. And recent reports, as mentioned by Dr. Cathy Te, would be the presence of malignancy. But essentially, it is this biliary cripple effect of the bile duct injury that we are mostly concerned about. And that's the reason why in 2017, as we have seen, that we formed the Palace Zero BDI campaign, but this could not have been done or could not have been successful without the collaboration with other organizations. So particularly the Philippine College of Surgeons, the Philippine Society of General Surgeons, and also the various chapters of these organizations, as well as the Palace chapters. And also this would have not been possible without the help of many individuals, including our past presidents, who joined us during this campaign. And with their support, it gave us more fuel to move forward and continue this advocacy for Palace. And as general surgeons or as fellows of Palace, we all share this desire to make our patients better and to prevent complications from the surgeries that we perform, especially for laparoscopic cholecystectomy. We all know that the gold standard for benign liver gallbladder disease right nowadays is that of laparoscopic cholecystectomy. And it has its inherent advantages that we are all most familiar with. But why is it that despite laparoscopic cholecystectomy being here for the past decades, or 2 or 3 decades, the injury from laparoscopic cholecystectomy is still 2 to 3 times higher than that of open cholecystectomy? And this results in increased morbidity, mortality, and even decreased life expectancy, as we know and has been published in literature. And we have blamed several factors for the cause of these bile duct injuries during lap chole. Poor quality imaging of equipment for visualization, as you can see in the video that is running here. This is a video that was taken in the early 90s. Biliary inflammation, aberrant ducts, biliary anomalies, or probably even lack of appropriate training and or experience by the surgeon.
So these are very important factors that we have to think about whenever we do a laparoscopic cholecystectomy procedure in order to anticipate the prevention of bile duct injuries. Also, during the early years of our training, one of the techniques that was being taught was the infundibular technique, which we now realize later on that this is not actually a good technique because what is apparent is actually not real. And this is an error trap that has been mentioned in literature. So what we were looking for was the funneling of the gallbladder infundibulum down towards the cystic duct, thinking once we see that funnel or that elephant's trunk appearance, we are now sure that it is the cystic duct. But actually, what is apparent is not real, and this funneling may lead to the fusion of the cystic duct and the common hepatic duct, thinking that it is the bile duct. So it is important to understand that infundibular technique may really not be the proper way of identifying the anatomy of the cystic duct. Okay, so going back to the infundibular technique, so what is apparent is not actually real, and this is an error trap, especially when sorry. Without the animation. You just need to press that. Okay. All right. So sorry about that. We'll just readjust the slides. So the problem with the infundibular technique is sometimes because of acute inflammation, we now develop fusion of the cystic duct with the common hepatic duct, making it appear as one structure. And as a result, this can now be mistaken as the cystic duct. And that is really a problem that we have to understand in order for us to anticipate that such a technique will not be useful anymore. The basic risk factors in bile duct injury would be to what we have experienced, and probably it's something that we can help us, is the failure to identify landmarks. We were so used in doing open surgery in the past, or open cholecystectomy, and the effect is that when we do open surgery, what happens is that we look at the biliary area from top to bottom. Apparently, when laparoscopic cholecystectomy came in, what happened was that because we're putting the scope into the umbilicus, we now look at it in a tangential fashion. And therefore, the anatomy may be a bit distorted and such that we fail to identify the correct structures. And number two, probably, is the failure to identify the true critical view of safety. And we've mentioned the true critical view of safety simply because there are certain when you talk to certain individuals, wherein you ask, especially surgeons, young surgeons or residents or fellows, you ask them what is the critical view of safety, and everybody gives a different definition of what a critical view of safety is. And therefore, in our campaign, we would like to also emphasize to everyone the true definition of what a critical view of safety is, so we will be placed at the same level of understanding. Basically, the main cause of bile duct injury, as shown in this paper by Lawrence Wei and his group from the UCSF, published in the Annals of Surgery, is that the primary cause of bile duct injury in 97% of the time is visual perception illusion. Visual perception illusion. And it is only 3% of the time that the cause is because of a technical skill. And because of this, we now understand that whenever a surgeon has a bile duct injury, the surgeon will swear that what he cut or what he clipped and cut was the cystic duct. Then realizing later on that he misidentified the common bile duct as the cystic duct. And in this particular paper explains the reasons behind this. And that is why we have to understand, and I would recommend everybody to look into this paper and understand the reasons behind this. The most common cause of bile duct injury, and we have to emphasize this as well, is due to misperception. Misidentification of the common bile duct as the cystic duct. And therefore, in this idea, we now have to integrate the concept of identifying the proper landmarks so we know where to start and we know where to avoid the hostile area. And to identify the critical view of safety as emphasized by Strasbourg and his team in order to minimize or bring down the risk of bile duct injury on our patients, or probably achieve even a zero bile duct injury, as what we advocated. So these are things, again, that we have to consider and we have to be very wary about. And putting this always at the back of our minds when we do a laparoscopic cholecystectomy. The most common cause of bile duct injury is misperception or misidentification of the common bile duct as the cystic duct. That is the number one. So why is it through the years, the incidence of bile duct injury has not decreased significantly in laparoscopic cholecystectomy, despite emphasizing the critical view of safety and promoting a culture of safety in cholecystectomy? I would like to think personally that one of the reasons is because we have not emphasized mainly on the true definition of the critical view of safety and how to achieve this. And we have not emphasized mainly as well as one of the factors, the landmarks that are important to identify in order to stay away from the hostile area. How does one achieve the critical view of safety in laparoscopic cholecystectomy? That's one aspect that we'd like to cover in this lecture. And do we really give emphasis on landmarks before, during, and after dissection in laparoscopic cholecystectomy? Again, just to emphasize, the most common cause of bile duct injury is misidentification of the bile duct as the cystic duct. Every surgeon who has injured the bile duct will claim that what he clipped and cut was the cystic duct. Let us remember this all the time when we perform our laparoscopic cholecystectomy procedures. The question is, why is this so? So we also, there was a state-of-the-art consensus meeting in SAGES in a couple of years back, and talked about the bile duct, how to prevent bile duct injuries. And this was a collaboration of different societies, and came out with some consensus statements, which we also would like to share with everybody as we proceed with our advocacy and our campaign. In PALES, what we recommend is the 4-port technique, and that is how we would like to teach our young residents and our trainees, that we should start in the 4-port technique, and I'll show to you later on why we want to start with this 4-port technique and not with a 3-port or a 2-port or a single-port technique. And this will be emphasized in the subsequent slides. So the first thing to do once we enter the abdominal cavity is perform a limited diagnostic laparoscopy, because we have to bear in mind that not only is bile duct injury a concern, but injury during access entry is also a concern, and injury to the underlying viscera. So we always want our trainees, when they bring in the scope, is to go around and check the abdominal cavity. Check for injury at the entry site. Check for any pathology that might have been missed preoperatively. And check the status of the gallbladder. So this will dictate to you whether you should proceed laparoscopically or where your trocar placements will be before you proceed with entering with the other trocars. Then the next step is to insert all trocars under direct vision. So we'll go through the steps one by one and emphasize certain tips. Insert all trocars under direct vision. And this is very important. Many times during the training of my residents or my fellows or my preceptees, given the opportunity to insert a trocar, being overzealous and over eager to insert that particular trocar, that by the time you swing the camera to them, the trocar is already inside. And we were not able to see how the trocar entered. So please make sure that every time the trocar is inserted, it is under direct vision at all times. It's also important that when we start to position the patient, we place in the position of the patient in a position of a reverse Trendelenburg in order to retract all other organs away from the operative site. This facilitates the retraction of intra-abdominal contents in a caudal direction, and then eventually facilitates exposure of the gallbladder area. And practically, we all follow this. Okay, so then we go to retraction. As far as retraction is concerned, it's very important to know that retraction is one of the keys in identifying correctly the cystic duct. Okay, just a second, we'll just have some technical difficulty. So just to emphasize, while we're fixing the laptops, that as far as retraction is concerned, it is one of the keys in the proper identification of the cystic duct and separating it from the common bile duct. So as far as the fundal retraction is concerned, the recommendation is to retract that fundus superior and lateral. Okay, is to retract that fundus superior and lateral. And that is what we see here. So what is the reason why we wanted to retract superior and lateral and not superior and medial, which we see in some of the cases that are presented to us when our fellows apply, when our candidates apply for fellowship, is that once you see that fundus retracted superior, vertical, and medially, the cystic now becomes parallel to the common hepatic duct. And when it becomes parallel to the common hepatic duct, it also becomes aligned with the common bile duct. And therefore, this might be one of the reasons why the common bile duct is mistaken as the cystic duct. And therefore, we want to retract it laterally and superiorly. Next, we also want to retract the Hartmann's inferiorly and medially. And it's very important to retract the Hartmann's inferiorly and medially because sometimes when we see the infundibulum, it retracts the Hartmann's superiorly and medially. And when it does, it also contributes to the parallelism of the cystic duct to that of the common hepatic duct and makes that cystic duct aligned with the common bile duct. Again, this may be a problem as far as misidentification of the common bile duct as the cystic duct. After we do that, we identify now also the important landmarks which we would like to emphasize. So for PALES, we have identified 5 landmarks when we started this campaign. And these were also the landmarks that were also published in some articles internationally. 1 is the right hepatic fissure or Rouvier sulcus. 2 is the first portion of the duodenum. 3 is the pulsating hepatic artery. 4 is the common bile duct. And 5 is the infundibulocystic junction. The significance of knowing these 5 landmarks is that it identifies a safe location where to start our dissection. And that is very, very important. It identifies the hostile area and tells us to stay away from there and start our dissection in a safe area. And this we would like to emphasize to our residents as well. Now let us identify the significance of each landmark. In the right hepatic fissure, the significance is when we identify it, or the Rouvier sulcus, we would like to stay above the Rouvier sulcus in our initial dissection as much as possible. Because below the Rouvier sulcus, we would see the area where the common bile duct would be. And dissecting below that will be putting you in close proximity to the hostile area. So we would like to avoid that. The second landmark that we have to identify is the first portion of the duodenum. And the significance of which is the common bile duct is always located above, superior, and behind the first portion of the duodenum. So if you find yourself dissecting above the first portion of the duodenum, you are in the wrong area. Stop and stay away from there. The next landmark, the third landmark, is the pulsating hepatic artery. And we see that here, the pulsating hepatic artery. If you see yourself dissecting beside the pulsating hepatic artery and it is now in that area, you know that parallel and lateral to the pulsating hepatic artery is where your common bile duct will be. So if you see a pulsating structure as you are dissecting, stop, think again, stay away from this area. And that is the common bile duct is parallel to the pulsating hepatic artery. The next fourth landmark is the common bile duct. If the common bile duct exposes itself to you, that is very good. Because we know that sometimes this is covered by fatty tissue. So all you have to do is eyeball it, visualize it, and then stay away from it. And you will see this beside the pulsating hepatic artery, and you will see this above the first portion of the duodenum. The fifth landmark, and the last landmark, is the infundibulocystic junction. And once we see the infundibulocystic junction, we know that this is a safe place to start our dissection, and not to what we were taught before, that to start the dissection, we have to be close to the common hepatic duct. So stay away from the junction of the cystic and the common hepatic duct, but stay close to the infundibulocystic junction. So this is an initial, safe initial dissecting area away from the hostile area. There are also additional papers published by Gupta et al. In 2019, as early as 2019. And they have a mnemonic called Be Safe. Similar to what we also advocate, here they have a mnemonic of Be Safe. So B stands for bile duct, base of segment 4. S stands for the sulcus ruveus and segment 4. A is for the artery, hepatic artery. F is for the umbilical fissure. And E would be the enteric structures like duodenum and stomach. And when they pass a line between the hepatic fissure, as well as the umbilical fissure, they now have a line called the R4U line. And the significance of knowing the R4U line is that above the R4U line is now the safe area. And below the R4U line is now the hostile area. And therefore, this is again an important landmark that we might want to consider during our dissection. So think of the 5 landmarks, think of the R4U line, and you now know where you should start your initial dissection. Okay, so again, emphasis on the lateral traction of the infundibulum, lateral and inferior instead of superior and lateral or medial. And you want this maneuver opens up the hepatocystic triangle of the cystic duct, common hepatic duct, and the inferior edge of the liver. Start the dissection at infundibulocystic junction. How do we dissect? Dissect in a manner that you are most comfortable with. You may use your Maryland dissector, you may use your hook, you may use your peanut pusher, you may use your irrigating suction tip, any manner that you feel most comfortable as long as you stay in that area. And one thing in mind that we should always remember is use your electrosurgery sparingly if you decide to use it, at only 1 to 2 seconds to prevent lateral thermal injury. One common problem that we encountered initially when we started doing this technique is we wanted to isolate the cystic duct and cystic artery right away. In our campaign, we tried to temper this. What we recommend is to release first the anterior and posterior leaves of the visceral peritoneum coming from the infundibulocystic junction in a V-shaped fashion. This now further distances the gallbladder from the hostile area and opens up the hepatocystic triangle. It allows the gallbladder to further distance itself and therefore places you in a position farther away from the hostile area. And next, we now dissect. After doing this, we now dissect the 3 structures: the cystic plate, the cystic arteries, the cystic duct. Some would dissect the artery and duct first and followed by the cystic plate, and others dissect the cystic plate, cystic artery, cystic duct. What is important is until these 3 structures are not completely seen, one should not clip or cut yet. Now let's go to the true definition of the critical view of safety. So it has been emphasized by Strasbourg about the critical view of safety. And what we have to understand is we must have a standardized definition of what a real critical view of safety is. So based on the recommendations by Professor Strasbourg, exposing the critical view of safety means we expose 2 structures entering the gallbladder, which is the cystic duct and the cystic artery. And we have exposed the cystic plate at least 1/3 of the posterior wall of the gallbladder. And another qualification of the critical view of safety is this structure should be devoid of fatty and loose areolar tissue. So again, expose 3 structures: cystic duct, cystic artery, cystic plate. The cystic plate should be exposed at least 1/3 of the posterior gallbladder wall. And this should be devoid of free of fatty and loose areolar tissues. We must remember that this is the true definition of the critical view of safety. Once we have identified that, we now go to the identification of these three structures in the doublet view, the anterior view and the posterior view. We should be able to identify the cystic duct, cystic artery, and cystic plate in the anterior view, and the cystic duct, cystic artery, and cystic plate in the posterior view. Now, does this work? Well, apparently in some papers that have been published in a study on approximately 6,000 cases, where each and every case they demonstrated the critical view of safety, especially in the doublet view, there was not a single bile duct injury due to misidentification of the common bile duct as the cystic duct. And if we look on the recommendations from the consensus meeting a couple of years ago, they also recommended that and suggested that surgeons use the critical view of safety for anatomic identification of the cystic duct and cystic artery, and preferably document this as well in either doublet photography, or you print it or put it in the record that you have identified this clearly. Are we now ready to clip and cut after identifying the cystic duct and the cystic artery? Are we now ready to clip and cut the structures? The answer of Dr. Ong is not quite yet. Okay. Okay. First, APALES would now advocate performing a zero bile duct injury timeout, similar to the consensus meeting recommendation that at least surgeons conduct a momentary pause to confirm his or her own mind that the criteria for the critical view of safety has been satisfied before clipping or cutting. And the recommendation also was to incorporate a critical view timeout. And we believe that this is important, similar to the timeout that we do as recommended by the WHO before we start our surgical procedure. And we now have developed in PALES what we call the PALES 2020 Zero Bile Duct Injury Timeout. And if you look at the screen now, this is the zero BDI timeout that we would like to share with everybody. You can take a screenshot and copy it and put it in your institutions. And this is how it goes. Once the surgeon has identified the critical view of safety in the anterior and posterior view, the trigger for the timeout will be the surgeon saying, "I am ready to clip." Once that is done, the circulating nurse, which is part of the team as well, will now be able to ask the surgeon and the members of the team the following. Are all the important landmarks identified? And the surgeon will answer yes. The next question is, are the criteria for the critical view of safety in doublet view achieved? The answer is yes. Enumerate, the next statement will be, please enumerate and show each structure in doublet view, which the surgeon will show to everybody in the team. Cystic duct, cystic artery, cystic plate in the anterior view, flips it over and says cystic duct, cystic artery, cystic plate in the posterior view. Once that has been achieved, the next question is to the surgical assist. And the question is, do you agree that it is the cystic duct? Only when the surgical assist agrees and concurs that it is indeed the cystic duct, that is the time to clip and cut. It's a tedious process, something to get used to, but it is safe. It is the safest we could be to prevent bile duct injury. So once that is done, we take out the gallbladder in the usual manner, extract it through the umbilical port. And in the past, some surgeons would stop, terminate the surgery, and move on. What we recommend is to reinsert the trocar, reinsufflate the belly, put the scope inside. And why we want to do this? Because we want our surgeons to reevaluate the operative site to see if there are any bleeding, bile duct injuries, bile leak, integrity of clips, duodenal injuries, and other intra-abdominal bleeding and injuries. Let us make this a habit, because if there is any injury at that particular time, the best time to address it will be during that same operation most of the time. So to do this is really something that we'd like to share with everybody. And for young residents, we ask them to verbalize it in order to make it a habit for everybody. Saying no bleeding at the liver bed, no bile leak. They verbalize this out loudly. Clips are intact. If you put 6 clips, the 6 clips are there. Or 4 clips, and the 4 clips are there. No bile duct injury, no duodenal injury, and the procedure now is terminated. So let us show you a quick video on achieving the critical view of safety that we have made as we give our lectures during the campaign. So basically, again, fundus is retracted superiorly and laterally, and the landmarks are identified. Just to emphasize, right hepatic crease, first portion of the duodenum, pulsating hepatic artery, the common bile duct, and the infundibulocystic junction. And as we identify, we start our dissection at the infundibulocystic junction and focus on the release of the anterior and posterior visceral peritoneum in a V-shaped fashion. Again, you may use your Maryland dissector. You may not use electrosurgery. If you decide to use electrosurgery, it should be used sparingly. And you should always know that you are away from the hostile area. We recommend focusing on identifying the cystic plate first. No clipping or cutting of the cystic duct and cystic artery until the three structures that we have mentioned are fully identified, which is the cystic plate, cystic duct, and cystic artery. And as that is done, we go now to the posterior to try to expose the cystic plate. And remember, cystic plate is exposed at least 1/3 the posterior wall of the gallbladder. There is the cystic plate. Now we release the posterior visceral peritoneum. And we do not go deep into the structures, just the visceral peritoneum. And once that visceral peritoneum is released, what is left now underneath are just the important structures, which is the cystic duct and the cystic artery. It also gives you an opportunity to identify if there are any other vascular or biliary structures in this area, because what you are practically dissecting would be loose areolar tissue in these areas. Always know where you are, above the right hepatic crease, away from the first portion of the duodenum. Now we identify the structures. Cystic duct, cystic artery, cystic plate in the anterior view, as you see on this video. And again, in the posterior view, we have cystic duct, cystic artery, and cystic plate in the posterior view. We have identified the structures, take a photograph. This is digital doublet view photography, and it can be also included in the chart. And once that is done, I am ready to clip. The PALES 0 BDI timeout is performed, and when that is concurred, then we are now ready to clip and cut the cystic duct and cystic artery. Which do we clip and cut first? It really depends on what is best exposed to you. There is no strong recommendation as far as which goes first. What is important is you clip both, putting 2 clips proximally, 1 clip distally, and also ensuring that you relax that Hartmann's before you apply the clip in order to prevent tenting of the common bile duct and the common hepatic duct, which may be included in the clip structure. And then remove the gallbladder in the usual fashion. So intraopcolangiogram is also could be a recommendation, then therefore would be needed sometimes in some surgeries. What is important is everybody is comfortable in performing an intraopcolangiogram during laparoscopic cholecystectomy. And there are many avenues of training where this can be performed in simulation for you to be most comfortable with. In the event of failure to achieve the critical view of safety, and this is a question all the time, what if we can do the critical view of safety? What if we cannot achieve the critical view of safety? Then comes bailout strategies. So bailouts in cases wherein the gallbladder is chronically inflamed or acutely inflamed on a chronic situation, and the critical view of safety cannot be achieved, do not force the issue of trying to identify the critical view of safety, and one has to bail out. The laparoscopic dome-down technique or the open dome-down technique has been advocated as well in the past, but we have to be very careful as far as this is concerned, as you can see in that warning sign or danger sign that I placed here. Because this also can be an error trap, and this can be dangerous because the cystic duct and the common hepatic duct would be fused together. A bailout procedure would be another option, would be the dome-down technique. And in the dome-down technique, it is important to understand that we leave a part of the gallbladder because it is chronically inflamed or acutely inflamed on a chronic affair. And therefore, we just unroof it and go all the way down, extract the stones, and we excise the anterior wall. There are two types of subtotal, just to mention it very briefly: fenestrating and reconstituting. Fenestrating is you try to close the cystic duct from the inside, and the reconstituting type is the wherein you leave a portion of the gallbladder and close that wall of that gallbladder. The disadvantage is that you maintain a remnant gallbladder, which could be a future, will have a future collection of stones in this particular patient. But what is important is there was no bile duct injury at the time of surgery. So this is a bailout in the event the critical view of safety could not be achieved. So just to give you, in the interest of time, we will not go through the entire video anymore as far as bailout strategy called the subtotal cholecystectomy. And you can see in this patient, it's really quite impossible or even detrimental to the patient if you try to achieve the critical view of safety because the structures are inflamed. And therefore, trying to separate the cystic duct from the common hepatic duct and identifying the duct, the artery, and the plate may cause an injury. So in this particular patient, you could see that what we did instead is to unroof the gallbladder, take down the anterior wall of the gallbladder, go all the way inside, check, remove and extract the stones, and go as low as you can. And what you have now is a wall, as you approach the common hepatic cystic duct, common bile duct area, which you couldn't see, there is a wall of the gallbladder that serves as its shield in order to prevent injury to these structures. And all you have to do is remove the stone and close the cystic duct from the inside, which we also do in open surgery, which can be translated to laparoscopic surgery. And here is a technique that we do, wherein we dissect the mucosa, the inner mucosa, go around it, and suture ligate it later on. And we are sure that we have not injured the bile duct because of that serosal wall, which serves as a shield to prevent going into the hostile area and injuring the common hepatic and common bile duct structures. So what happens if we deviate from identifying the landmarks and deviate from achieving the critical view of safety in laparoscopic cholecystectomy, or deviate from the option of doing a bailout maneuver? Then complications will set in. And these complications, the most feared, will be bile duct injuries because patients become biliary cripples. As my last slide, my take-home message is, our take-home message from the committee is this: appropriate supervised training and education in laparoscopic cholecystectomy by a well-trained mentor is very important in the guidance of all surgeons wanting to do laparoscopic cholecystectomy. During dissection, always identify the 5++ landmarks to avoid the hostile area. Always identify what we now know after this lecture, the true critical view of safety in a doublet view fashion. Anterior and posterior, identify these structures, and then perform, always mandatory when we do the CVS, is the zero bile duct injury timeout. This overemphasizes that we are not negligent in ensuring safety to our patient. Use an intraop cholangiogram, which is the gold standard, or an ultrasound or an ICG as indicated, depending on your training and availability, when you want to verify certain anatomy in the as you dissect. And you must be able to perform bailout maneuvers in a hostile hepatocystic triangle where you cannot achieve the critical view of safety, or you do not want to force the issue of identifying the critical view of safety because of the chronic inflammation or the acute inflammation. Dome down technique, again, be very cautious. This may be an error trap. We have to emphasize on that, and therefore you have to be guided properly on how to perform this. 2, a subtotal cholecystectomy would be a very good option in order to address the problem and not injure the bile duct. And what is important is no injury occurs at the time of surgery. Or you can do just put in a cholecystostomy tube as another bailout procedure. Or in our country, we still value the conversion to open surgery as a bailout maneuver since we're all trained in open surgery. And number 2 is if we decide to convert to open surgery, preemptive conversion, that is before injury occurs, is better than reactive conversion. So And last but definitely not the least, and we have to emphasize, call for help in the event that you encounter injury, or in the event before you encounter injury and you have already difficulty, call for help from my colleague who is trained in laparoscopic cholecystectomy or open cholecystectomy and how to address your concerns intraop. So ladies and gentlemen, I hope this lecture has enlightened all of us on the safe laparoscopic cholecystectomy technique, emphasizing on the 5 landmarks plus additional landmarks, as well as achieving the critical view of safety, as well as options for bailout strategies. Thank you very much and have a pleasant afternoon. Maraming salamat.
Thank you very much, Dr. Ike Papi Mendoza. So there are 2 questions. No, we can actually address these 2 questions first, and then we will proceed to the next lecture. Dr. Ike, there's a question. Can you comment on the statement of Professor Nassar?
The comment is, can you comment on the statement of Professor Nassar that injuries usually occur during the dissection, which makes the demonstration of the critical view of safety also a risk for injury to common bile duct? Very true. I agree. And that's probably the reason why, despite the critical view of safety being emphasized over the years, the bile duct injury does not come down. Because we did not emphasize on how to properly dissect for the critical view of safety. Number 2, that's why in our advocacy, we emphasize on certain landmarks that we have to identify first before we initiate any dissection. And these landmarks tells us where we should stay away from. The hostile area where the bile duct injury the bile duct may be potentially injured. Therefore, emphasize on the landmarks, stay away from the hostile area, stay away from the bile duct, dissect the critical view of safety in an area that is safe. And we can only know that this area will be safe if we follow those landmarks, because we stay away from the hostile area. That is how I would like to answer that question.
Thank you. Thank you, Dr. Ike. So we will address the other questions later during the video critic. Thank you, Dr. Mendoza, for that excellent lecture.
Thank you, Dr. Ong. Thank you very much. Thank you, everyone.
Okay, for our next topic. Okay, this is our next topic. Yes, this is me. Good afternoon once again. I will be discussing another advocacy of PALES, which is the zero misuse or the zero minimally invasive use of surgical energy. This advocacy was launched last July 2019 as a complement to our Zero BDI campaign. Why do we need another advocacy campaign? In literature, injuries from electrosurgical use are the second most common complications in minimally invasive surgery, following abdominal access in laparoscopic surgery. Bile duct injury is the least common injury, but has the most devastating outcome. In essence, our focus is to avoid bile duct injury, but we are undervaluating the effect of electrosurgery used in all laparoscopic procedures.
But the NBC4 I-Team has found that some of these surgeries can cause lifelong problems, even death in rare cases.
It should have been a routine medical procedure for Andrea Huber.
20 minutes of minimally invasive surgery. But just a few weeks into her recovery, Andrea was rushed to the emergency room. Andrea had a severe infection. She was close to death. How could a routine laparoscopic procedure go so wrong?
Stray electricity from the device that was used ended up damaging my bowel.
Found that thousands of stray energy burns occur each year. Some are fatal, others result in the need for lifelong medical care.
He, meaning Murtha, went in for a routine, minimally invasive surgery, was discharged. They hit his intestines. He was taken to the hospital 2 days later. And as we all know by now, he was in intensive care where he stayed until he died.
He will be mourned, and we're awaiting some official reaction.
Okay. Next slide, please. Okay, my talk is about electrosurgery. Many advancements in energy devices have been made in the last couple of years. However, in spite of the frequent use in our surgeries, they remain poorly understood. The use of surgical energy cannot be overly emphasized in minimally invasive surgery. It speeds up the surgery, minimizes blood loss, makes our operation easier, and supposed to decrease surgical complications. However, we use it recklessly without knowing about the complications and or consequences of its uses. Probably we saw one and did one, because that was how we learned during our residency training. We must always bear in mind that these devices are dangerous weapons if not used properly. Have you ever read an IFU, or the information for use in all equipment or devices you buy or use? Majority of us ignore these IFUs because, let's face it, we are mostly visually driven. We see how it is used, we buy one, then use it immediately because we are accustomed to its use. These IFUs normally contain only product specifications of the device or machine, nothing else. It may demonstrate a couple of steps for use, but naturally will not indicate possible complications regarding its use. In order to prevent electrosurgical injuries, one must fully understand the principles behind and how to properly use these devices. Hence, a fundamental knowledge of ESU is warranted. Thus, the Zero Misuse was born. The goals of this PALES advocacy are to raise awareness, understanding, and proper application of energy devices in order to prevent energy-related injuries, coined as zero misuse. During residency training, electrosurgery and cautery are regarded as similar, but they are entirely different from each other. There are two forms of energy use in surgery, radiofrequency and ultrasonic. I will discuss the radiofrequency only. So let's have a short test. I would not be disclosing the correct answers yet. You can choose the answer and keep it to yourself first. What do you call this device? What type of energy does ESU utilizes? When dissecting tissue planes, what is your ESU setting? When coagulating a vessel, what setting do you use? What is your preset voltage for coagulation and cutting? What are the advantages of bipolar device from a monopolar device? To begin my lecture, I have to stress that electrosurgery is not the same as quote-unquote cautery. Electrosurgery is the use of radiofrequency alternating current in the tissue to produce a desired effect, while cautery is the destruction of tissue by passive transfer of heat. What is cautery? A good example is a flat iron. When the iron is heated and a person touches it, the skin will get burned because there is passive transfer of heat. Another example is the branding iron used on livestock. In the operating room, what do you most commonly hear? A surgeon says cautery or burn. If you like to burn a tissue, then the machine should be called a cautery machine and not an ESU. An ESU uses radio frequency energy through monopolar and bipolar instruments to vaporize, coagulate, cut, or desiccate the tissues. Hence, it is incorrect to term them we do as burn, when in fact, what we really want are the ESU effects. I hope after this lecture, the usual terms like cautery, cauterize, or burn should not be used anymore in the operating theaters. To elucidate, shown is the electrocautery pen. Electrocautery runs on direct current. Direct current is usually seen in batteries. When you activate the pen on the tissue, there is no movement of electrons and protons in the tissue. No heat is produced inside the tissue. The proton that is heated in the tip of the pen, this is the concept of electrocautery. Say in Wart's application or flat iron I mentioned earlier. This is electrocautery. Now we go to electrosurgery. Before one understands electrosurgery or energy sources, one has to understand the principles behind electrosurgical frequency. The ESU basically does two functions. It converts a low voltage alternating current from 60 Hertz outlet into high voltage radio frequency current. Example of these are the effects of different radio frequency levels and its applications. Radio frequency is between 200 kilohertz to 3.3 megahertz. To review electrosurgery, electrosurgery runs on direct current. Electrosurgery, meanwhile, runs on alternating current. When you activate an electrosurgical pen on a tissue, there is movement of electrons and protons inside the tissue. The back and forth movements of the electric charges by about 500 times is converted to heat energy within the tissue and not the tip of the pen. The tip of the pen only runs the current into the tissues. Therefore, the tip of the ES pen is not heated. This is electrosurgery. This is a visual representation between electrocautery and electrosurgery. So in electrosurgery, the electricity passes from the pen to the patient and back to the machine. Now that we have understood the differences between these two electrocautery and electrosurgery, we now discuss the properties of electricity. For a given resistance R, current I is directly proportional to the voltage. In other words, if you increase the voltage through a circuit whose resistance is fixed, the current goes up. If you decrease the voltage, the currents go down. If you increase the resistance, no matter how you increase the voltage, the flow of current remains the same or increases slightly. We usually do this in surgery when we fail to see the desired effect at a given voltage setting. We always think that increasing the voltage will give us the desired results. In a monopolar cautery, the current passes from the machine to the pen, to the patient, then back to the machine from the dispersive electrode. The patient is part of the circuit. The advantage of using monopolar instruments is for the tissue dissection due to its greater tissue penetration. However, it has a wider lateral thermal damage. On the other hand, in bipolar circuit, the energy is confined to the area where the instrument is applied. It does not pass through the patient, unlike the monopolar circuit. You don't have a dispersive electrode as well for its function. A bipolar instrument has two arms on one handpiece, minimal lateral tissue damage. It can be used in patients with pacemakers. However, unlike monopolar instrument, it has no dissection capabilities. As mentioned earlier, electrosurgery current flows through the tissue to produce the desired effect. The effective tissue coagulation occurs between 50 to 80 degrees centigrade, and around 90 to 100 degrees centigrade, it desiccates and vaporization happens. Do take note, though, that at higher temperatures, between 200 to 300 degrees centigrade, there will be tissue carbonization, or what you call eschar formation. This demonstrates that the longer you activate your pen, the higher chance for lateral thermal spread, therefore, more damage to the tissue. So, only short intermittent activation should be used during surgery. These are the effects of electrosurgical activation on the tissue: vaporize, desiccate, or coagulate. It depends on the power setting, the type of instrument, and how you apply it on the tissue. Now we discuss the power density. The power density is defined as the amount of current per unit area. It is dependent on the surface area of the instrument that is being applied to the tissue. The smaller the surface area of the instrument, the higher the power density, thus the higher the current. For example, when one applies a monopolar needle to a tissue, there is a small surface area being in contact with the tissue, therefore a higher current density is being produced, causing a greater amount of heat. This produces a cutting effect on the tissues. This is in contrast with using a ball. The larger surface area of the ball comes in contact with the tissues, producing a lesser current density. Because of the lesser amount of heat that is produced produces a coagulation or a fulguration effect on the tissues. The choice of electrode size and how one applies it to the tissues affects the cutting and hemostatic effect, much more than the choice of cut or coagulation mode. The manner by which the surgeon applies the tip of the electrosurgical pen has a significant effect to the tissues. Observe that the standard ES pen held vertically and the other is horizontally. Both are receiving 50 watts. But look closely at the effect each produces to the tissue. The one with higher power density cuts the tissues more efficiently compared to that the medium or lower power density. At the same wattage with different density effects, the tissues differently. The preset waveform of a coagulation mode are pulses of high voltage and low energy current. Therefore, you only burn the surface of the tissue and charring is produced. The charred tissue sticks to your instrument because only the superficial tissue is desiccated. Next slide, please. In a cutting mode, there is continuous high current and low energy voltage. It penetrates well, deep into the tissues, but does not produce charring on the tissue. Instead, it only produces a white coagulum, which does not adhere to the tip of the instrument. This method of desiccation is ideal when forceps instruments are used to coagulate a vessel. Here's a video showing the effect of cutting mode to tissues using a bipolar forceps. The high current of cutting mode creates a full thickness coagulation of the vessel without eschar formation. Therefore, a good vessel seal is one that coactively coagulation is performed slowly via continuous low voltage output, the cutting mode. Here are some safety measures to remember in using the ESU. Use the lowest power setting possible. Verify power settings before starting. Indicator alarm should be loud enough. No fluids on top of the unit. Patients should not be in contact with any metal objects and should be laid on an insulated table. We now move on to the complications of ES uses. Mechanisms of electrosurgical injuries: active electrode trauma, inadvertent activation, current diversions, direct coupling, insulation failure, capacitive coupling, dispersive electrode burns, and even smoke inhalation-related problems. In laparoscopic surgery, it is advisable to activate the ESU when you are already touching the tissue. and not activate it as you are nearing the tissue. Avoid the following when applying the dispersive electrodes: bony prominences, metal implants or prostheses, scarred tissues, hairy areas, adjacent to leads or electrodes, pressure area points, skin discoloration injuries, limbs with circulatory compromise. Direct coupling is when an active electrode is applied to a metal, then it is in contact with the tissue to bust for hemostasis. So when you are using your left hand dissecting and you try to coagulate using your right hand, it will cause a direct coupling effect. Insulation failure is when there are breaks in the insulations of your instruments. The smaller the break, the higher the current that leaks, the higher the risk for injury. This commonly happens on repeated reprocessing of disposable instruments. Next slide. When the current flows through the insulated instrument, the metal trocar serves as a capacitor. The metal trocar absorbs the excess current and transmits it to the abdominal wall. If a plastic trocar is used, it will not serve as a capacitor. So the electricity goes to the area of least resistance. Most of the energy then is discharged at the tip of the instrument and may cause severe injuries. In laparoscopic surgery, the ideal setup should not be a hybrid setup. Avoid use of insulated metal instruments and plastic trocars, but rather use an insulated metal instrument and a metal trocar. Capacitive coupling happens more frequently during high voltage waveform, open activation of the system, active ES cable coiled around the clamps. Surgical gloves can cause capacitive coupling effect, especially when you have a sweaty hands. Here are some precautions in minimizing ES complications. Use short intermittent activations. Use the lowest possible setting. Always check the instrument insulations. Do not activate open circuits. Ensure that your instruments are not in contact with each other. Use all metal trocars rather than a hybrid setup. I'll just give you a brief discussion on advanced bipolar device. The main use is for vessel sealing. With combined compression and controlled heat, it provides you an effective vessel seal up to a maximum of 7mm vessel diameter. Please watch the video.
Clamping on tissue compresses the vessel walls. Current begins to flow through tissue, creating heat. Native tissue proteins denature, while water turns to vapor and escapes. LigaSure technology fuses the intimal walls of the vessel, resulting in complete lumen occlusion.
Thank you for your kind attention. Good afternoon. Okay, that ends my lecture. So at this point, may I now turn over the stage to Dr. Juvie Villaflor, who will now moderate the next session, which is the video critic. Dr. Juvie. Joining the panelists will be Dr. Allen Buenafe. Allen, where are you? Are you in the panel? Together with Allen is Dr. Jose Macario Filona. You've seen him a while ago. Also, Dr. Miguel Mendoza, and our CSE chair, Dr. Jeffrey Domino. Juby, you have the floor. I'm going to share the video. Juby, can you hear me? I cannot hear Juby. Okay, are our panelists on board? Okay, so Alan is here. Jeffrey, Ike, Dr. Faidona, we have still Dr. Ate with us. So Matthew, I think our presenter is just connecting right now. So, okay, Matthew.
Good afternoon,
you
sir.
Can hear us? Okay, I'll be projecting the video. Juby, are you with us, Juby? So I cannot see Dr. Juby. I will just moderate on this session. Okay, Matthew.
Okay, sir. Can you hear me, sir?
Yes, just give us a short introduction.
Okay. I would like to say good afternoon to everybody and to our panelists and our audience. I think the previous speakers were talking about how to prevent bile duct injuries, and in these videos, we will see actual bile duct injuries, and hopefully we can learn from these videos. So, will I share my screen, sir, or
this one? It's playing.
Okay.
So can you give a brief, just the age of this patient and just a short history?
So the first case is a 44-year-old male who came in with a 4-month history of right upper quadrant pain. On physical exam, there was no signs of acute inflammation. There was no Murphy sign. All the enzymes were normal in this patient. Ultrasound, there was multiple gallbladder stones with non-dilated gallbladder, common bile duct. Basically, the plan was to do a laparoscopic cholecystectomy. So, 3-port technique was used in this patient. Visualization of the trocars was done. There was no signs of injury during entry. The anatomy was delineated at the start of the surgery, and on the observation of the gallbladder, there was no signs of inflammation.
Okay, thank you. Can we hear from our panelists? Alan, you want to say something? Kuya,
Yes.
yeah.
Yeah, Mon, thank you. Can you hear me?
Yes.
Yes, thank you, Mon. The video stopped here, but we
Yeah,
haven't.
I pause it. Just can you
Okay.
just give a comment on a 3-port technique and how you see this video? What do you think?
Yeah, just looking on the video and even on the picture that's paused right now, I would want always to see the edge of the waist of that Hartmann's pouch, and how you retract now the gallbladder going up and trying to open up that callus would be very important for you to identify the edge now of your Hartmann's pouch and supposedly where the beginning of your cystic duct going downwards would be, and that would be that's the start of my my procedure. I would always look first on the anatomy, try to identify if there's a sulcus, where the sulcus is, and I would want to identify the Hartmann's pouch in relation to where my duodenum is, because in between I would know that the dissection would be starting off just right after that Hartmann's pouch.
Thank you, Alan. Kuya Maki, you want to say something?
What I would say is that the 3-port technique, number one, is not for amateurs. Okay, you have to be a very skilled laparoscopic surgeon to be able to get away with the 3-port technique. especially in this video that you are showing, the liver is quite heavy, and you'll have some problems lifting. And when you lift this, as mentioned in the previous lectures, it's very difficult as well to achieve the position that you need in order to be able to dissect this safely. So for our participants, be wary about the 3-port technique, because these are usually just reserved for people who are already very skilled in laparoscopic surgery. And studies have already shown that the 3-port technique also has a higher incidence of bile duct injury compared to the 4-port technique.
Thank you. Thank you, Kuya Maki. Yes, Jeff, go ahead.
Yeah, just to add lang, I hope now if you look at the videos, sorry, yeah. When the video stopped, I was trying to find where the bleeding is coming from, because there was already initial bleeding. So I hope, though this is an edited video, see there, I hope the surgeon at this time has already evaluated where the bleeding is before really starting the dissection. And I think that's very important, because if you proceed without really checking the bleeding, you might have more problems later on. So you have to be wary about your surroundings as well. Thank you, Mon.
Thank you. Any comments from our panelists? Ike, you want to say something?
Yes, Dr. Ong. Yes, excellent comments by our other panelists. I totally agree. And that's why we have to emphasize two things. Number one, before the start of any...
Can you hear Ike?
Can you hear me?
Not too much.
Not too much.
Can you make this closer, please?
Yeah.
Closer lang, closer.
Closer the mic. Thank you.
All right. Thank you.
Yeah.
Thank you.
What about?
All right. So
is
we
that
have it
okay?
here. All right. So,
That's better.
Better?
Yep.
Okay. Thank you. So yes, I agree with the comments of our panelists regarding this. In addition to what they have mentioned, I would like to say that there are two things I'd like to emphasize. One is the access entry. So if you see anything that is unusual, like bleeding, for example, as was mentioned, it has to be assessed first, and that's part of your limited diagnostic laparoscopy. And number two is agree that the 4-port technique is what we advocate. The 3-port technique may be a good technique under the hands of experienced laparoscopic surgeons who've done a lot of cases, and they still follow the same principles of identification of landmarks, as well as the same principles of exposure of the critical view of safety. Then that would also be a good technique. I agree, Dr. Failona, that single-port techniques, or I have a higher, less than 4-port techniques, particularly single-port techniques that has been published, have higher bile duct injury rates than the standard 4-port technique. And I think that's similar to what we are experiencing here in our country as well.
Thank you, Ike. Matthew, can you comment on your labels?
Because this was a 3-port technique, and the retraction of the gallbladder was done at a superior area, the common bile duct and the cystic duct is parallel when it is being retracted. So we can identify the duodenum at the inferior portion, the Breuer sulcus, the right portion. And you see the common bile duct going superiorly, which is in line with the cystic duct because of the way the retraction is being done in a 3-port technique.
Thank you. Ike, would like to comment on the labeling of this image?
Yes, I think, let me see. Is that the Breuer sulcus right there? Yeah, probably that is, no? No, probably higher, a bit higher. Or you don't even, it's not really that prominent, no? The Breuer sulcus.
Yeah.
I don't see exactly. Sometimes in cases where you may not see the Breuer sulcus. Yes, that's the one right there. Right. Okay. So agree with as far as the landmark is concerned. So the first portion is there. The common bile duct appears to be that one. The Breuer sulcus probably would be that one.
Not sila.
But he is actually grasping, I believe, already part of the area where the cystic duct may be.
Okay.
That may be something that you might want to consider as well. I agree with the comments that yes, when you tend to pull the traction of the area where the infundibulum or the Hartmann's pouch is, you tend to pull it upward, especially in the 3-port technique where there is more tension than usual, especially for those who are not experienced in doing this. You align the cystic duct with a common bile duct, and you make the cystic duct parallel to your common hepatic duct. And there is the tendency to misidentify the common bile duct as the cystic duct.
Okay, thank you, Ike. Any comment from our panelists? Kuya Maki?
No, I think Ike has already mentioned that.
Okay, so let's proceed with the video. Yes, Ma'am Cathy? Yes, Ma'am Cathy.
Okay, just one small last comment maybe. The label of Rouvier sulcus, there actually shows where the posterior pedicle that is going in. So in the way I see it, the label of the cystic duct may actually be too low, because this part just above the labeled Rouvier's sulcus that was identified as the Rouvier sulcus may not be the real sulcus, because it is already below the posterior pedicle of the porta hepatis, or the pedicle, the hilar pedicle. So we are actually a little lower than expected.
Yes, that's right. I agree, Kathy. That's why it was kind of doubtful at first where the labeled Rouvier sulcus is. And that is why we have to understand that not all patients would have that prominent Rouvier sulcus that we would see, no? Or the hepatic tissue.
Up to 10% will not have it.
Yes. Yes, so we'll have to rely on other landmarks as well to guide us. I agree. Thank you, Kathy.
Thank you. Kuya Jeff, can you comment on this initial dissection?
Yes, I noticed the way he used the hook is a bit deep, no? I mean, when you use the hook, once you have tried to make the hook, you try to, before you put on the diaphragm, you have to put it away from the gallbladder. Otherwise, you may also burn. That's one in the structures behind it. So if you were able to hook already part of the peritoneal reflections, try to lift it, and hopefully you just burn or you just cauterize the peritoneal reflection and not the structures behind it. Thank you, Mon.
Thank you. Allen? Kuya Allen?
Yes, Kuya.
Comment?
With the way the section is being done, I think the section was started off right in the middle of where your cystic duct and your common bile duct would meet up. I would usually start my dissection a little bit higher, or right after the waist of that, seemingly where your Hartmann's pouch would be. If I'm doing my 3-port dissection or even my single-port dissection, even with this one, I would start off first actually with anatomical, familiarizing myself with the anatomy of the patient. How? So you're trying to hold on to that Hartmann's pouch. The tendency for the surgeon is to lift it up. And then in that way, when you lift it up, you tent now the cystic duct and the common bile duct, making it appear like the common bile duct as your cystic duct. So the way to do it is try to hold on to that Hartmann's pouch first, and then with your right hand, try to push the lever up, and then try to open the triangle. Try to identify the triangle. In that way, you'll have now an idea where supposedly your important structures would lie, rather than go straight away, tenting it up, holding that Hartmann's pouch up, and then you'll have a straightening of your cystic duct and your common bile duct. Thereby, you'll have a higher incidence of mistakenly identifying your common bile duct as your cystic duct. So try to go for anatomy first.
Thank you, Kuya. Ike, you want to comment?
Yes, as I was watching the video on the dissection, I could see that he was dissecting really low and close to the first portion of the duodenum. And once you notice yourself in that particular area, you have to pause, no, stop, and reassess everything. Reassess your traction, reassess where you are, look at the other landmarks. Because once you see yourself dissecting above the first portion of the duodenum, you are already in a hostile area. So stop. Even if you say that is the Ruvier sulcus, and probably it's not the Ruvier sulcus, you could see that the dissection is still below that area where they mark as the Ruvier sulcus. And that is already closed down, as was mentioned by Kuya Allen, that's very low, no? So probably go higher up, stop, go higher up, reassess your traction, reassess where your left hand is. And I think the left hand is there at the area where the cystic duct is.
Thank you, Kuya Ike. Any comments, Ma'am Cathy, Ma'am Catherine?
I've already commented in the beginning. It's too low for me, and the anatomy doesn't look right. So I think for now that's it, and the rest
Thank you.
are the same.
Yeah. Okay, let's continue.
Kuya Mon?
Yes,
Yeah.
Kuya.
My point is, like for me, I'm looking on how the surgery was being done, how the dissection is being done. I'm also guilty of this one. So sometimes, because of trying to go fast and then try to proceed to your other patients, sometimes your dissection would be like this. But then again, just like what Dr. Mendoza, Kuya Ike have said earlier, once you've seen the dissection going on and pushing through like this one, and like Cathy, what Cathy have said, try to look on the anatomy again. Okay, sometimes you're lost and you don't know that you're being too low. Prior to the dissection, prior to clipping, release everything and then look again on the anatomy. If you're too near the duodenum, so parang warning sign, oops, I'm too near the duodenum. Try to lift it up and then try to open that triangle. So parang I'm too far away from the normal anatomy. Try to identify. So always, if you look on the PALES Zero BDI 2020 program, lagi may stop muna, try to check on the anatomy, try to check on the two structures, like what Ike have said earlier during his lecture. So always look on the structures first prior to putting all the clips and everything, and then before cutting. So these are the important steps that we need to do. But mind you, during the dissection of the video, sometimes I'm guilty also of this one. So ang importante lang doon, prior to the clipping, prior to the cutting of that structures, important structures, try to identify again. Go back to your anatomy. Ang sabi nga natin, di ba? Move your telescope backwards again. Try to look on the whole picture, then go back with your telescope and try to identify all the important structures.
Okay, Dr. De Vera, go sir.
Yeah, paki-atras nga doon sa medyo bandang umpisa. Yung kita yung, sige, atras pa na konti. Yan, that part, paki-pause lang, paki-pause. Yan, and then paki-balik doon. Yan, okay. You could see na yung dinadissect niya is going towards the hilum already. So, if it's going to the hilum, then probably nagdadissect siya doon sa hepatoduodenal area na. You could clearly see yung pagkaka-place ng hook niya. If you follow it downwards towards, it's moving towards the hilum. So makita natin, he's dissecting already the hepatoduodenal, and sabi nga ni Cathy, he's dissecting too low. Although it doesn't appear too low kasi hindi naman ganun kadikit sa duodenum. And probably this patient has a very redundant CBD. That's why it could, pag tinraction mo, it could appear as the cystic duct dahil redundant siya. But from this clip, we could see na hindi na dissect niya. If you follow it posteriorly, nagpupunta na siya doon sa hepatic hilum eh. Oh. So he's dissecting already doon sa hepatoduodenal area and nasa danger zone na siya, in other words.
Thank you, sir. Juby, you're here. You want to take over? Kuya Juby?
Sana, ano
Hi.
nangyayari?
Mr. Yes, Ma'am Cathy. Mr.
Just a
Moderator.
follow-up
Yeah.
to Dr. De Vera's comment. And that's why from the start, when you see the posterior pedicle earlier that I pointed out, without really acknowledging this as a Rouvier sulcus, the possibility of a variant in anatomy is high. And when you have labeled it wrongly in your mind from the start, the procedure will proceed as it is in your mental, whatever is already designed in your mind. Therefore, the labeling or the identification from the very beginning should be correct. And when we spotted the low starting point because of the posterior pedicle and the absence or the not usual Rouvier sulcus length and slit-like appearance, it heralds a possible anatomical variant. So Dr. De Vera also mentioned possibly a long redundant CBD. So these are always the possibility. And if you look at the falciform ligament, he is dissecting below the falciform. If you draw a diagonal line from the posterior pedicle up to the falciform, it's behind the falciform, and which is really too near the duodenum. So what I'm trying to say is that the duodenum may not be a very good landmark. The more reliable landmark will really be the pedicle. There, in the absence of a Rouvier sulcus, you should be able to identify that. And going in, dissecting into the hilum, into the pedicle, smells danger.
Thank you, Ma'am Catherine. Juby, take it
Yes.
away.
Okay.
Yes,
So
Jeff.
who's holding the video? Who's controlling?
I have the control. I have the control.
Okay.
Juby, can
So
I?
panelist. Yes.
Yeah, Juby, can I add some comments? Okay.
I think
Jeff.
signal. Yeah, Juby, your signal is not good.
Yeah. So can I proceed, Mon?
Yes, go ahead,
Yeah.
Jeff.
Yeah. The comments of Kathy and Dr. De Vera is quite important. No? The initial dissection is really important, and the identification of the landmarks are actually important as well. The only problem is every patient has a different looks. It's a different view and a different image. So that's the challenge of the surgeons. So sometimes there are surgeons are unable to really identify the proper landmarks, or sometimes the dissection when they start maybe too low or maybe sometimes too high. And based on this video, if you look at the video, the surgeon here was able to identify this structure, and maybe on his mind has already made up his mind that this may be a cystic duct. And that's precisely why it's important to also dissect the CVS, the critical view of safety, to really know where you are, to really know if you are really low or you're really high before you really clip on this. And I think that's one important that surgeons encounter during the surgery. They're not all the same. And I think before, it was mentioned also by Alan that before you really clip, before you cut, you have to identify all the vital structures. And you can see here, on the, maybe, I don't know, maybe on the mind of the surgeon might have already been thinking about the cystic duct. But that's why we recommend strongly to try to dissect also the posterior cystic plate. That way, you'll be able to identify also if you really are low or if you really are high. So that's just to emphasize, Mon or Juvie, that besides or before really clipping, you really have to look for the CVS. Sometimes we start a bit low, sometimes we're a bit high. Go ahead, back to you, Juvie.
Jeff, Juvie, Just an addition to Jeff, because he mentioned about the cystic plate. I was actually I wanted to wait a little further to touch on that, but since you already pointed that out, normally the conduct should not start from where he started. I would have started up there on the cystic plate above, opening the posterior cystic plate and the anterior cystic plate instead of jumping right into the cystic duct and looking for the cystic duct. The usual conduct for me is going behind, opening the cystic plate of the posterior and the anterior, and then that magically will show you where the CVS most likely is in case it is not a difficult dissection. But otherwise, try to avoid going that direction or that first step in your dissection, which is straight into the assumed cystic duct or cystic duct CBD junction, because that is the most troublesome part.
Okay, thank you. Ike, would you like to say something?
Yes, thank you. Yes, excellent comments. I would just like to emphasize as well on behalf of the committee that when we talk about landmarks, we do not look at a landmark as one single landmark. For our participants, when we talk about landmarks, we have to look at all the landmarks that are available to our knowledge before making and deciding where we should be dissecting. So all these landmarks that we talked about this afternoon should be correlated with one another for you to make a decision on where you should operate. We don't just look at the duodenum, we don't just look at the reverse sulcus, we don't just look at the pulsating hepatic artery. We don't even just look at the infundibulous cystic duct. We correlate everything, then we probably use additional landmarks like the R4U line that Catherine has mentioned, and make a decision where to start our dissection. So these landmarks should all be considered and not one landmark in particular all the time. Second, we probably have to change our mindset. And our mindset in this particular video, which was a mindset which I had before many years ago, decades ago, is to isolate the ductal structure, which I perceive as the cystic duct, isolate it and treat it. So in this particular video, that is exactly what we were doing after residency in the up in the mid-90s. So isolate the cystic duct, what we think is the cystic duct, isolate it, clip it, and cut it. And that is exactly what is happening here. And now we know better that we have to identify and clean up the peritoneum first, the anterior and posterior visceral peritoneum, and also clean up that cystic plate that was mentioned a while ago. And look at that area first before deciding to clip and cut it. So that's all I want to share.
Thank you, Ike. Dr. Maki, would you like to comment on this image?
I would be very uncomfortable in clipping that structure because, for one thing, I don't really know. It's too big. So I would have to double check whether that structure that I am clipping is really the system. So instead of proceeding in clipping that, I would further release the gallbladder away from the bed, exposing the cystic plate as mentioned before, and re-identify first the structures before applying any clips. Because even if you pull back from, because in this video we have seen that the clip has already been placed but no transection has been done. Even if there's no transection that has been done and you pull out the clip because you think that's the bile duct, you might have caused some ischemia of the bile duct already, which might cause bile duct strictures later on, if indeed the one that was clipped was the bile duct. So I would be very uncomfortable in clipping this because it's quite big. I agree with all of the panelists that normally I would dissect as well higher than what was shown. And I'm not a hook guy, so I normally use a Maryland and peel everything, starting at the Hartman cystic duct junction going down and identifying the structures as I go along.
Thank you, Kuya Maki. Any more comments? Ike, would you like to? Okay, Alan, are you still here, Alan? Jeff?
Yeah, okay, Mon. Just proceed. I'm okay.
Okay, so if you notice, if you notice, the lecture of Dr. Ike, you should have identified at this point before clipping the critical view, which is Dr. Ike. Alan, would you like to say something?
It's okay, Kuya.
Ike is busy.
Mon?
Yes, Kuya. Sorry.
Yes, go, Jeff. Juvie, go.
Oh, sorry. Hindi ako oriented sa video, but I think mukhang 3-port ba to? Tapos mababa na yung
yes.
clip. Hindi nga na-identify yung CVS, and then hindi na-release yung cystic plate. So I think for me, agree with the other panelists. It's a low clip. He clipped it in a very in an anatomy na uncertain pa. Most likely a big structure, maybe the CBD. So sa lecture ni Ike, hindi niya na establish yung mga steps na clearly it wasn't established, especially the critical view of safety. But I think the critical part here, whether you're using a 3-port, as long as you are able to release the cystic plate, probably you will be able to identify other structures like the common hepatic and the CBD. So that's it. I think we need to dissect further. Supposedly, the surgeon needs to dissect further before he clips a structure. So hindi niya na-achieve yung critical view of safety.
Okay. There's a question from the panelists. Is infundibulous cystic junction the most reliable and maybe the safest landmark? Can you comment on that, Dr. Maki?
Again, the infundibulocystic.
Is the infundibulocystic junction the most reliable and safest landmark? Is it a safe landmark to rely on the infundibulocystic junction?
No, because that can always be a misperception. So a lot of injuries actually occur due to misperception or misconception of what you see. So kaya nga 'di ba doon sa lecture ni Ike, wala yun doon yung using it as a landmark. It has to be other landmarks like the Rouvier sulcus and all the other landmarks that was mentioned by Ike. But I wouldn't use that as an exact landmark for safety.
Thank you. Ike, would you like to comment on this now? So you can see the image.
Where's the image?
There in front of you. Okay. So, do not. You can talk, Ike. Yeah, you can talk.
Okay, so what is the question?
Can you comment on this image? Because if you notice, there are already clips applied to a structure below.
Yes, that's right. And this is one of the common images that we would see when we review bile duct injuries. As they do the dissecting, this surgeon believes 100% that this is the cystic duct. And this is a very common image that we see, or a video that we see as we review the bile duct injury cases that come to us. As you can see, the bile duct was clipped and cut, and when the gallbladder was relaxed, that area where the clip was located very close to that first portion of the duodenum. And when that gallbladder was relaxed, then you say, and before even the cutting, you have to pause and stop. Why is my clip there? It's too low when you relax the traction. And from there, the the scissors should have not been brought in, but then a reassessment again of the landmarks should have been done. Number two, that it was already clipped and there's no cystic plate yet exposed. And the cystic plate exposure, the cystic plate tells us that we are away from the high loop. And we know those structures already, that we are in a safe area because we're away from the high loop, because we have exposed that cystic plate. Here, not yet. So that was a committed step, point of no return. The bile duct was clipped and it was eventually cut.
Thank you, Ike. Kathy, Ma'am Catherine, you want to comment?
I'll comment later.
Okay. Sir Maki, you want to comment, Sir Maki?
I agree with Ike. No, I will not cut unless I'm pretty sure that what I'm cutting is the cystic duct. So, for me, the surgeon should have investigated first. If when you cut and the thing that you cut disappears somewhere, then obviously there is a problem.
Okay, Jeff, are you here, Jeff?
Yeah, sige lang man.
Okay, Kuya Allen, you can now comment.
Yes, Kuya. The same comment with all of the faculties. I won't do my clipping unless I'm sure of all the structures that I'm looking at. Trying to look on the critical view of safety. Easier said than done. It's especially for markedly inflamed area of that common bile duct of that gallbladder. It's quite hard to do the dissection. But then again, I don't do any shortcuts. I would always identify all the tubular structures before I put my clips on.
Thank you. Okay, so Ike, there was bile a while ago. You saw bile leak, and then the surgeon continued to clip another structure. Can you comment on that?
Yeah, once I see, my personal comment on this is, whenever I see bile during my dissection, I stop and reassess, even if I know that bile came from the area of the infundibulocystic junction or the area of the Hartmann's or somewhere in the gallbladder. I know it wasn't the bile duct. Still, the presence of bile warrants a reassessment and stop all dissection. Wash, reassess, check, and do not proceed with any other step of clipping or cutting. So we should not be complacent and say, "Oh, I'm sure that bile came from the gallbladder, or that bile came from the Hartmann's pouch," or those things. Think that there might be an injury. Also, you see bile, think that I might have injured an extrahepatic biliary structure. I might have injured an anomaly, an aberrant anatomy, and one that warrants a reassessment. And go back again to the landmarks that we've discussed. Go back again to the traction that we have discussed, and reassess it again.
Thank you, Ike.
I have a question.
Yes.
I was just wondering if what was the surgeon thinking of when nakakita na siya ng bile, tapos nag-clip pa siya nung common hepatic. So dalawa ang kinlip niya, tapos pinutol niya. I don't know. I'm just thinking what was in his mind. What do you think as panelist? Kasi parang tinuloy pa niya yung gallbladder surgery eh. Di ba dapat pag ganyan, stop ka muna?
So I think going back to the comment of Ma'am Cathy a while ago, so the surgeon created his own anatomy and proceeded until he was able to finish the procedure. No? So, but to the panelists, when you are intra-op, or for example, the one doing this is a resident or a new consultant, and something happened and he was able to identify, oh my God, this is the common bile duct. What should be the proper attitude during that time? So anybody can go?
Yes, correct.
Wants to go? Maki? Yes, Maki, go.
Call for help. Once in this part already, after the initial cutting, and you think that you have injured the bile duct, then you have to document and call for help immediately if you are not an experienced hepatobiliary surgeon, because repairs of the bile duct, if not done properly, would cause more problems for the patient and will cause also more problems for the biliary surgeon who will reconstruct it if ever a stricture develops. So call for help.
Thank you. What about Ike? What will you do?
Yeah, that's a very good question, Kuya Mon. And really, that happens to me. I can just imagine the concoction of emotions that will come afraid, angry, scared, worried, and all these things. And therefore, with these emotions, my judgment on what is the next best thing to do might be clouded. And therefore, I agree with Dr. Kuyamaki that I think it's best to set the ego aside and call for help. There is no shame in that. Because what we have to prioritize is the safety of our patient. And if calling for help will improve the outcome and calling the best help possible available, then that probably will make a difference in this patient's outcome.
Thank you, Kuya Ike. Yes,
Mon,
yes, go
if
ahead.
I may, Mon, if I may.
Yes, Juby.
If I remember, I don't know, just recalling from previous bile duct injury campaign lectures natin sa road trip, I think Dr. Arcilla mentioned before, meron siyang ginawang 6C, di ba? Once you're there, it's either you curse, you contemplate, parang you converse, control, and communicate, then you consult, parang ganyan. And these are things that should parang be in your, parang on your mind. But definitely, you need to consult somebody. Tigil muna siguro before anything. I don't understand why he has to finish the operation.
Okay, Kuya Maki, go ahead.
As Ike mentioned, no, about the emotions and all those things. So even if you are actually an accomplished biliary surgeon, studies have shown that if these things happen, it's better that you ask someone to reconstruct for you and not you be the one reconstructing, because of the, as mentioned by Ike, no, yung emotions mo, yung apprehension mo ng legalities and everything. So even in the bile duct safety courses of SAGES, that is what they recommend, no. Even if you are skilled in reconstructing this, you better call for help and ask another one to help you reconstruct.
Thank you, Kuya Maki. Kuya Ray, are you here? Kuya Ray? I think he's busy. Ma'am Kathy, I have a question.
Okay, sige.
Ma'am Kathy, so if this happened to somebody and he called for help, there was a clean transection of the common bile duct, what will be the best repair for this? What will be the best management during this time?
First, I would want to do an IOC. I would need to know the anatomy first. So there's a possibility to do an IOC there since the other end is open. I think, is that the hepatic duct that was ligated?
Probably, yeah. Yes.
Maybe we can do an IOC there. And then take it, decide from there. Another thing also is definitely to stop dissecting and not to injure further, because any vascular injury at this time would be very detrimental to the outcome of the repair. I didn't see the cystic artery earlier. Was it clipped? Parang hindi ko kasi nakita na the cystic artery.
There was one structure, yes, at the back. Yeah, I think it's here.
Not so sure whether that is it, or was it ligated with or burned or whatever. So it was not, in short, it was not really properly identified, all the structures. So first, I would want to rule out any vascular injury because it would spell the outcome. And then an intraoperative cholangiogram. If it is an injury that can be easily repaired, then I would help in repairing the injury at that time. Yeah, it's possible.
So in this case, ma'am, would you do a primary repair? Would you do a definitive repair in this patient?
Yes,
For
a definitive
example, the
repair can be done.
transection is a high hepatic duct injury.
Yes, I would do a Roux-Y, entero and bilioenteric bypass rather than an end-to-end anastomosis of the bile duct, because the biliary injury usually is accompanied by vascular injury, and stricture rate will be high. Bilioenteric bypass is shown to be more long-lasting in that sense, in that aspect, and whether we do an early or a late intervention, it really depends on what type of injury, the expertise available, because recent studies have shown that early and late repair doesn't differ much if there is no vascular injury and if it is done in the hands of experts.
Thank you, Ma'am Cathy. Jeff,
At
are
the
you
right
here, Jeff?
location. At the right location. We tend to do it as high as we can because the hepaticojejunostomy serves us better. It's high and wide. That's the clue. You want it high and wide. At the bifurcation, you can even design your anastomosis there to make it wider.
So, Ma'am Cathy, you'll do the repair, right? I mean, during the injury, or will you delay and do the repair later on?
Well, if at that time I am there, I can do it. Do a hepquino and then repair it early, if it is possible. Yes.
Okay. Thank you, ma'am.
I wouldn't
Jeffrey?
wait.
Okay, Jeffrey.
Yes, thank you, Mon.
Do you think an ICG would help the surgeon in the dissection in this case?
An ICG will help in the initial dissection, knowing that, well, we can see now how the surgeon approaches surgery. Perhaps with an ICG, he'll be able to be guided with his initial dissection. As you mentioned, I mean, as it was mentioned by other panelists, that the approach was really low. Now, if you look at the before dissection about this gallbladder, there was not much fats, which means that with an ICG or a fluorescence imaging, it could fluoresce well and may guide the surgeon as to where could be a good approach as well. And during the dissection, the surgeon may be able to be guided with by the way things are. But just to emphasize that besides the ICG, you still have to do the standard of the recommended dissection, which is to really look for the cystic plate. It's not because you have an ICG you won't dissect anymore the cystic plate and the other structures. It is still recommended. So the ICG fluorescence is just to help guide. Back to you, Mon.
As a follow-up
Yes,
there,
ma'am.
Mon.
Yes.
At this time, the ICG may help because the perfusion of the liver can be detected if there is any vascular injury or not. However, because there is a biliary injury, you will also have a leak of the ICG into the system, into your vicinity, and that would also contaminate the area. I mean, not contaminate, but make it difficult to see. But definitely, you would be able to assess your vascular structures perfusion using your ICG at this point to exclude the possibility of a vascular injury. And if on ICG you don't have a vascular injury, then you can clearly see the hepatic artery and the liver would be beautifully perfused, then I can safely say that there's no vascular injury, and I would proceed with the definitive repair.
Okay, thank
Want
you.
to follow up,
Jeff, yes, there's a follow-up,
Yes.
Jeff.
Yeah. With regards to what Kathy said, I agree. If it's at this point, what the use of ICG is actually for vascularity and not for biliary. But it is still prudent that to call a more experienced surgeon, because if you decide to have an ICG and you saw that the vascularity is okay, the next step is to really look for a more senior or more experienced surgeon, because the definitive the choice or the decision to do definitive will be coming from the most senior or the most experienced surgeon. So that's it, man.
Thank you. Jeff, one more thing. There's a question here. What is the timing of giving the dose if you're the dye if you're using an ICG?
That's right. So when you use an ICG, it could give you a vascular phase and a biliary phase. So as what Kathy mentioned, at this point, the duct has already been cut. So the use of ICG is more on the vascular anatomy rather than the biliary. Because if biliary, better to give it before the surgery, because it takes time before the bile will go or will fluoresce at the biliary tree. At this time, it will just fluoresce the liver.
Jeff, can you give us the timing? What time should we? How many hours before the surgery?
If you want to look for the biliary tree before the surgery, at least a minimum of at least 1 hour or more can already be done. Some of them, they can even be given before 1 hour. I mean, about 30 minutes. So it depends upon your dose as well.
Ma'am Kathy, you want to comment on the timing? Yeah.
Yeah, we've done the different timing from 30 minutes to an hour to 6 to 8 to 12 and 24. So for us, the optimal timing is between 6 to 8 hours, and that is also because we can save actually 8 hours, because we can save on the bottle of the vial of ICG for economical purposes, because you only need so much. So the dose that we give is about 0.5 per kg. So you would still have half of the bottle, which you can use intraoperatively for your vascular identification. So an hour, 8 hours pre-op for me is the most ideal, which the liver is not too green and you see the bile duct beautifully. And if you give the ICG late or just 30 minutes or an hour before, it is very hard to see the contrast because everything is green. Your liver entirely is green. Then your contrast ratio there would be so high. So it becomes difficult to differentiate the bile duct and the liver. So that is for us the most optimal timing is between 6 to 8 hours, and you can keep the half of the vial for OR.
Yeah, agree. Agree. That's the optimum timing, 6 to 8 hours. Last question for the repair. Some surgeons would really be very afraid if they see a transected common bile duct, but there is a chance that they can do an end-to-end repair. Can you comment on that?
Me?
Kathy, yeah, please.
End-to-end with the T-tube?
Yep.
I think, yes, it can still be done if it's something that you're comfortable with a clean transection and with no vascular injury. But the thing is that you need to keep the T-tube there for quite a while. You need to keep it there for a long time. And still, even if you've removed it, the stricture rate is still higher than designing a nice hepaticojejunostomy up there in the hilum. So I personally prefer bilioenteric anastomosis to a T-tube, a repair over T-tube. Though it is easier to do the T-tube repair, I think, primary anastomosis.
Thank you, ma'am. So I think we're running out of time, but now can I ask the panelists to give at least a few words of comments or tips to our audience based on the video that you've seen. Can we begin from Alan? Alan?
Yes, Mon. Thank
Yeah,
you.
can you give some tips to our audience avoiding bile duct injury?
Well, first and foremost would be accustomed with the normal anatomy of the gallbladder. Everyone knows that I always do a single port lap chole, but even though if I'm doing a single port chole, a 3-port chole, or a 4-port chole, my dissection does not change regardless what procedure I'm doing. So even if I'm doing a single port chole, I would always try to mimic what a 4-port laparoscopic cholecystectomy would do. So what's that? I would always identify that critical view of safety. I would identify all the tubular structures. I don't clip any structures without being sure of those structures, because once you clip and once you cut, it's a reversible. You cannot, at the end of the day, it's always the patient who would suffer for the procedures that you've done on this patient. So always look on that anatomy. Try to remember that critical view of safety. I think ICAS has done a very good lecture on how to how to identify that critical view of safety. So you just follow it. I don't have any qualms in, don't take it against me if I say that I really don't criticize you if you would want to do a 3-port lap chole or a single port or a 4-port, as long as you do it safely and properly. You identify that critical view of safety, and that's important.
Thank you. Okay, thank you, Kuya. Kuya Maki? Or Philona?
I think, well, Alan has mentioned almost everything. I just would like to comment on the reconstruction using primary repair. I think, yes, you can do that depending on the level where the transection is. The further away from the duodenum and the further away you are from the hilum, the chances of stricturing rate is higher. But dyan naman daw si Ray para i-dilate yung stricture just in case you develop a stricture. Now, for preventing injuries in the bile duct, the lecture has been given. Just follow what Ike has mentioned, identify the structures, the anatomic structures properly, and always do the timeout before you cut anything. And that would probably make you a safer surgeon in doing laparoscopic cholecystectomy.
Thank you, Kuya Maki. So thank you for stressing the 0 BDI timeout. I hope everyone will use that. Ike, can you comment also on the question of dome down technique and use of the 0 degree scope with your comment? Go ahead.
Just very quickly, the dome down technique was included as one of the bailout procedures. However, it's not a totally 100% safe procedure, especially when we know that there are error traps to this procedure in chronically inflamed and acutely inflamed gallbladders, wherein there is diffusion of the cystic duct with the common hepatic duct. And the error trap and pitfall in the dome down technique is that if you stay close, as you do the dome down and you stay close to the subhepatic area, you tend to travel towards the hilum, towards the common hepatic duct, injuring probably also the artery. And therefore, the key here is really can be used in cases wherein it is not there is a good interface between the gallbladder and the liver. Number two is that you stay close to the gallbladder when this is done and not migrate towards the common hepatic area. And number three, if you decide to do this, you should be trained to do this by somebody who has been doing this. If not, then I would advise not to do it at all if you are not trained to do this, because there are error traps in this procedure. Better do a subtotal cholecystectomy. So better do a subtotal stents. And with regard to the okay, did you hear that?
Yeah.
With regard to the use of the 30-degree or the 0-degree, there was a comment here about the use of the 0-degree. I used to use 0-degree for many years, and I felt that was the best scope for me, only for the reason that that was the only available scope I had in our hospital. And while everybody was shifting to 30 degrees, I was still using 0-degree. But when I tried the 30-degree, it's like the doors opened and the vision became clearer, and I can look around corners, so it can help. And now I use 30 degrees for my laparoscopic procedures. You should try to use that. Those are still stuck with 0 degrees. You would see the benefits of using a 30 degree, but you have to have a well-trained camera operator for that. So with regard to my comment, as the final words for this session, laparoscopic cholecystectomy technique has evolved already through the years. And at the time when I was doing the technique was very different. And I just had to get out of my comfort zone. And even if I felt that my technique was the best technique already, and after listening to all our mentors and our international friends and looking at published literature, I said to myself, I better evolve as well, because this has already been proven to be safer for our patients. So my technique before I changed, I evolved. My technique evolved to what it is now, which we think would be probably for the moment, the safest technique that we can offer to our patient. Who knows, it might change again in the future, but at the moment, this is something that the Committee of PALES on PALES Zero BDI advocacy would like to share with everybody. So hopefully we all keep an open mind and continue to share our experiences for the betterment of our patients.
Hello?
Hello? Yeah, hello. I'd like to go back to Maki first. I think he has a follow-up message.
My message is mainly for the younger surgeons. Don't forget your open. Be well trained in the open technique, even the difficult ones, because that is your back door. No, if you cannot do it laparoscopically and you convert to open, then at least you are trained to do it. That is the current dilemma now in the US. They don't know how to do open, and they are now forced to do difficult or this bailout procedure because they cannot do the open. That's the reason why the bailout, the fenestrating, the reconstituting, kaya na-invento yun no? Because these surgeons found out that since the younger American surgeons no longer know how to do open difficult cholecystectomies, when they open or convert to open, they have more problems. So they cause more injuries. So butit dito sa atin, we are still training our residents to do open first and then laparoscopic. So don't forget your open. Hindi pa pwede na you're not also skilled in doing open surgery and just laparoscopy.
Okay, thank you, Maki. Yes, go.
Actually, that's precisely what I wanted also to as a message to the audience, like what Kuya Maki said. It's really about the open technique. It seems that That's what was implemented to really show everybody that things that injury can happen, and this is really one way to humble down the surgeons, because it seems that yes, we teach them the competency, but sometimes the character and the ego and the conscience is can be probably relayed by our faculty, by our experts, by our pillars of the society, coming from our lecturers today. So I guess basically it's really about patient care, patient safety, and quality surgery for everybody.
Okay.
So
Thank you, Jovi. Yeah.
I think that's basically why we are still here for the CBDI campaign.
Thank you. Jeff, you can go now. You can give your comments now.
Okay, thank you very much, Mon. Just have 2 points just to give tips to our attendees. First of all, you see every case is really unique. They're not the same. And that's why one of the message that really stick out with me from my mentors, that every case that you get, every case that you plan to do, or every case of laparoscopic cholecystectomy, you have to do your best as if it was your best surgery, and that way you are prepared. Because my second point will be, sometimes the most simplest, you thought that it's the most simplest case, it's an easy gallbladder, maybe with an aberrant or maybe a complicated one, or sometimes your guard as a surgeon, sometimes they go down. So that's why if you really perform this and you really approach this each case as your best surgery, then your guard will be up and you'll be very cautious in doing that. And that's the attitude that we want for it to accomplish your safety outcomes. Thank you, Mon.
Thank you, Jeff. So I think we need to go on with the next topic, because it is also related to this video critic. It's what are the steps that you need to see during the dissection? What are the steps that you need to follow to avoid bile duct injury? And these steps should not be, you should not move to a shortcut. You do not jump from one step to another to avoid bile duct injury. Okay, let me now give the floor to Dr. Don Rosello, who will be the moderator for this session. Dr. Rosello, we can't hear you.
Yes. Yes,
Yeah.
ma'am.
Okay.
Can you hear me now?
Okay. Yes, we can hear you.
Okay. Thank you.
Okay, for our next speaker will be again Dr. Miguel Mendoza, who will be showing to us the 12 steps in performing laparoscopic cholecystectomy. Kuya Ike? Wait, I will stop share. Okay. No, you have the mic. Yeah, you can.
All right. So thank you very much, Kuya Mon, and thank you very much for that interesting discussion and insights from our panelists who have contributed very much to the PALES Zero BDI campaign and advocacy. Thank you very much to all of you. This campaign would not be possible with all your insights and all your help as well as your support. The topic I'm tasked to discuss now is on the 12-point objective structured intra-op evaluation on a lap codec procedure. And I hope everyone understands that this is the standard that we would like to see in the videos that you would be submitting when you apply to become a fellow of PALES in the future. So these are the things we review. So take note of this. because this is very important. And this is what actually the committee under Dr. Ong is looking into. So the 12-point objective structured intra-op evaluation checklist consists of the following: abdominal access entry, limited diagnostic laparoscopy, subsequent trocar insertions, the gallbladder traction, the landmark identification, the exposure of the true critical view of safety, the performance of the zero bile duct injury timeout, the clipping and cutting, how it is done, the gallbladder dissection from the liver, the extraction, the re-evaluation of the operative site, as well as the closure. If we look at the abdominal, let's go through this one by one. So we would like to see access through the Hassan technique. So when you submit your videos, we would like to see the insufflation, that it is less than 14 millimeter mercury. And the flow rate should be starting at low flow and not at high flow immediately. Second step that we'd like to see is you performing the limited diagnostic laparoscopy. So when we perform the limited diagnostic laparoscopy, what we want to see is you're checking for bowel injury entries, possible and injuries during access, abdominal access. We bring the scope around quadrant per quadrant just to check if there are any other intra-abdominal pathology that we may have missed during our workup. And then focus the scope or camera at the gallbladder area to see the status and location of the gallbladder. Let's go to the third step. We also would like to see that as the trocars are inserted, since this is an unedited video, that the trocars are inserted under direct vision, and what you're submitting are actually 4-port technique lap codes. Even if you can perform it using a 3-port or a single port, what we want to see actually, and the committee wants to see, is the 4-port technique that we are advocating at this point in time. Fourth step that we want to see is the gallbladder traction. We want to see that your fundus is retracted nicely, gently, superiorly, and laterally. I would like to see your Hartmann's pouch or infundibulum retracted inferiorly and laterally. So those are the things that we see, because what we see now in videos is the fundus is retracted superiorly and medially, and the Hartmann's is retracted superiorly and medially as well. The fifth step is we want you to at least point the landmarks, the landmarks that you would want to identify in laparoscopic cholecystectomy. So maybe with your Maryland or any other instrument, you just point at the right hepatic crease, you point at the first portion of the duodenum, you point at the pulsating hepatic artery, you point at the common bile duct, and you point at the infundibulocystic junction. At least, you may want to show other structures like the R4U line, the base of segment 4, and so on, and the umbilical fissure. But this is the minimum that we would like to see that you have pointed out, showing us that you truly identified the landmarks before starting. I would like to see that you are starting your dissection at least close to the gallbladder and not close to the cystic duct, common hepatic duct junction, because this is where we feel that this would be the safest area to start. I would like you to see focus that you are releasing the anterior posterior visceral leaves of peritoneum and not attacking the cystic duct right away and clipping it. We want you to see that when you use electrosurgery, you use this sparingly during the video that you submit. We want to see as well that you have exposed the cystic plate with at least 1/3 dissection of the gallbladder free of fat and loose areolar tissue, as well as exposing the cystic duct and cystic artery. This tells us that you have not only identified the landmarks, you conducted your dissection safely, and you have exposed the critical view of safety. And we want to see as well that you have identified the critical view of safety anteriorly and identified the critical view of safety posteriorly, and that is known as the doublet view. The seventh step, do a 0 BDI timeout. That is one that we would like to see as much as possible. We can show that and probably pausing for a moment before you actually clip and cut. Or you may want to show the template of the 0 BDI timeout as part of at the end of your procedure. So, and we want to see as well on step number 8 on clipping and cutting. These are the things that the committee wants to see. Relaxation of the traction of the Hartmann's pouch, so that we know that you are conscious not to tent that common bile duct, common hepatic. We see that you applied 2 clips, and that is what we are recommending. on the patient site and 1 clip at the specimen site for both the artery and the duct as well. And we want to see that after you clip this, you are looking for structures or trying to see if there are any other aberrant anatomy or accessory ducts as you go through. Of course, that is something that you may want to show by zooming in or taking a clearer look of that area. And then removing the gallbladder from the liver bed, the usual fashion. The 10th step is extraction. So you not necessarily placing the gallbladder in a specimen bag. We want to emphasize this, that this is not a standard. This is an option technique. If you do this, that is fine. If you don't do this, that is also fine. Extraction of gallbladder through the umbilical incision. That is what we want to see. And 11th step is bringing that scope back in, because we want to emphasize that it is important, again, to do a limited diagnostic laparoscopy before you terminate the surgery. Therefore, we want to see you inserting the trocar, reinsufflating the abdomen, and checking for bleeding at the liver bed, checking for bile leak by focusing the scope there, checking for the integrity of the clips, checking for ductal injury, checking for duodenal injury, and bringing the scope again around the different quadrants to check for any other injuries or bleeding that we may have missed during the initial onset. And last but not the least, of course, closure is also important, that we want to see you remove the trocars under direct vision to check if there is any residual bleeding after we have decompressed or the trocars have been removed. And closure of the umbilical fascia under direct visualization to ensure that we know that you perform a safe surgery without injuring the viscera during the closure. And when we look at our operative evaluation or intra-op evaluation, we look at this, what we call a specific procedure-specific checklist for lap calling. And these are the 12 steps that we have talked about. And this was explained very well a while ago by our president, Dr. Tan. As far as the details of the checklist that we do, your videos are evaluated by a committee who is blinded from those who submitted, the names of those who submitted, as well as the institutions. And they just see numbers, no? Numbers now of the videos. They do not see who gave it. And this is a more objective way of assessing the videos that we see. So the scores are 0, 3, 5 as we go along. 5 is the perfect score, 0 did not perform it. But what is important really here is number 6, step number 6, which is exposure, step number 5, and step number 6, which is the exposure of the critical view of safety. That is what we want to see. And even if they pass all the other steps, but the critical view of safety is not identified, then that is a video that may not pass through the committee, may be reevaluated by the board again. So make sure these 2 steps are clear. It's a pass or fail rating for this step. So again, for everyone who wants to apply, this is one way for us to ensure that every member and fellow of the society will adhere to the safest technique that we can offer at this point in time. So this is something that has been designed and is for the benefit of everyone. Of course, this may change in the future, this may vary, this may evolve again, like any technique that evolves over time. But for now, this is what we are looking for in the community. Thank you very much for your kind attention, and I hope this was helpful in your perspective as far as laparoscopic cholecystectomy is concerned and joining panels. Thank you.
Okay, thank you so much, Dr. Mendoza. Are there any comments from our panelists? First of all, can I ask Dr. Bonifay if you have any comments with regards to the checklist?
Yeah, Don, thank you. Thank you, Ike, for a very nice lecture. I don't have any comment. It's one of the advocacies of the society that's quite really very important. And I would like to invite all of the attendees to please attend the opening ceremonies for tomorrow, because one of our keynote speaker is actually Professor Brandt, who's one of the pillars, and he's the originator of the safe cholecystectomy program that was initiated in 2014. He's the past SAGES president. And because of the program that Michael Brandt has started with, together with Professor Strasberg, when they came up with the paper of the Critical View of Safety program, that became actually the cornerstone of everyone, of all the societies around the world. I can still remember his speech, Professor Brandt's speech during his inaugural as president of SAGES, trying to challenge everyone to spread out the good news of the critical view of safety, to have a safe cholecystectomy program. And that's what Mon Ong has started for the PALES Zero BDI program, together with, of course, Ike and all the board of PALES. Congratulations, Ike. It's a very nice program. It's a very nice lecture, and I don't think I can add anything more to it.
Thank you very much, Kuya Alan. Thanks.
Okay. Thank you, Alan, for the very nice comment. So please attend the opening program tomorrow. Professor Brandt will be there. And any other comments from our other panelists? Dr. Kathy Te? Any comments?
Thank you, Don. I think something that I would like to add is the clinical human factor. Most of the technical factors have been a lot. I mean, it's a complete list, the technical factors that Ike has mentioned, and his presentation also showed the different steps in achieving the CVS. But let us always remember the human factor that we need to have during the procedure. And it is important to have teamwork and effective communication. We have to empower our assistants. And I think that is something that we lack. Many of our juniors, our assistants, they are afraid to speak up. We need to be assertive. If we think there is something not right, speak up and say that something is not right. I don't think we should proceed. I suggest or I recommend, the way I see it is this. And as the senior surgeon, let us not take offense, because sometimes we, as I've earlier mentioned, we have designed it in our mind. You've already designed the anatomy of the patient in your mind, and that's what you're going to go by. But another person next to you may have a different way of interpreting the anatomy. So the human factor there is very, very crucial. So apart from being meticulous, being aware, and being safe, we have to have that situational awareness all the time, and have our assistants empower them. Let them do their job. Let them speak up, not only mechanically standing and retracting, but thinking and observing and speaking up. So that would really complete your Zero BDI timeout, because the timeout will not serve anything if nobody within the operating room is ready to challenge you or is ready to speak up. So that's one important thing that we need to stress in our advocacy as well. Prudence trumps ego.
Thank you, Dr. Te. Can we address there's one question that was posted on the chat box. It's actually asked by Dr. Vincent Matthew Roble. He's actually here. He can ask the question himself. Would you like to ask the question yourself, Dr. Roble? Unmute yourself.
Hi.
Yeah.
I would just like to ask the question regarding the removal of trocars under direct vision. The recommendation for the pandemic is to desufflate first before removing the trocar. So how can we visualize already the removal of the trocars if the abdomen is already desufflated, or something like that?
Very good question.
Good question.
I think I will.
I think somebody will call somebody.
Happy.
Anyway, no, the steps in the design of the checklist was done actually prior to the pandemic. Yeah, and we know that the reason why we designed that step of removing the trocars under direct vision is that we want to see for any. But now, at this time during the pandemic crisis, I don't think it would be prudent to do that. It would probably not be safe for everybody, knowing that you're pulling out the trocars and you are also letting air escape into the environment. When the recommendation by the society as well as other societies is to evacuate the smoke as well as the pneumoperitoneum through a smoke evacuator device prior to the extraction of all this. So that's one thing that we might want to reconsider, and because safety, of course, of everyone in the OR is also important. So that is one, and that's one thing I would like to comment that during this time of the pandemic, not all the steps, especially that part, would be crucial in determining the checklist, whether you will pass or not. That's something we have to address.
Okay, thank you, Ike. To all the participants, would like you to note that Dr. Raymond Andrew Ong has placed a link on the chat box wherein you could see on how the evaluation for the LabCo videos will be performed. So it's very important. So when you're sending videos for evaluation, this could be a very good guide. We hope that you keep this guide, okay? And because this guide was made so that we could decrease the amount of bile duct injuries. It is worth noting that if there was a study wherein how many bile duct injuries and when do they usually occur during the training of during the the practice of a surgeon, and initially some of the bile duct injuries, if the surgeon doesn't have enough guidance, usually it will occur during the first 50 cholecystectomies. That will be the time that most of the bile duct injuries would happen. If you have a surgeon who has been guided, with a mentor up to 50 or 100 cholecystectomies, most of the bile duct injuries will start occurring between 200 to the 400th case. And there was a study on this. And this is because the confidence is building, one. And second, the surgeon will start doing the more difficult cholecystectomies. So those are things to contemplate. When you're doing your 200 to the 400th case, this is the time to be, more careful. And looking at the video earlier, that is a video or that is a mistake or a bile duct injury performed by somebody who has done almost 7,000 cholecystectomies or laparoscopic cholecystectomy. So, there's no time to relax, whether you're doing your first 50 or you're doing your 6,000 or 7,000 cholecystectomy. Any comments from Dr. Raymond Ong or Dr. Jui Villaflor? Thank you, Dr. Ong, for the link.
Yeah, so that's a very important message, Don. No? The number of procedures the surgeon performed is not it's not a license for you to perform an injury. No? So you have to really take every procedure seriously, because one patient, one injury would give him a problem for a lifetime. Okay. So anyway, so I think we have discussed a lot, and it's already 5:06. I promised Jeff to finish at 5. So you want to give your final message, Don?
Final message. I guess that was the final message for me.
Okay, so
Doctor, I would like to invite everybody to the opening ceremony. You've been invited by Dr. Alan Buenafe. Please join us in the opening ceremony tomorrow.
Thank you. So, Jeff, our CSE chair, would you like to say something?
Yeah, Mon, thank you very much. And really quite surprised that the number of attendees really very very high, and it seems that the session was very good. The discussion was also quite very relevant and important. The panelists were the licensed one. So we're glad that the discussion went well. Despite some signal fluctuations, we were able to do it. And yes, as Alan and Don has mentioned, we'd like to invite you tomorrow to our opening ceremony. And for those who are still interested to join the leadership course after this, we'll close the link and then just join into the link for the leadership course. It will be open for the first 100, but we will have a YouTube link for those who want to hear the leader or the mentors of leadership. It's a very good lineup of speakers with the course director, Dr. Cathy Te. So thank you very much, Mon. Back to you, Mon.
Thank you, Kuya Jeff. Message from Cathy? No? Okay, Alan?
Tomorrow, just see you tomorrow. I've talked too much.
Alan?
Thank you, Kuya Mon. So we'll see you tomorrow. We promise you even with COVID, the Board of Palace with our president promises to give you a fruitful Congress. And please listen to the keynote speaker. You'll be very interested. If you look on the lectures that everyone has been doing for Zero Bile Duct, even the MISUs, for the FUSE program, our keynote speaker is one of the pillars of the SAGES program, especially for the Safe Cholecystectomy program, which is the precursor of your Zero Bile Duct injury program, and of course the misuse and the FUSE program of the United States. Even the FLS program is one of the key leaders with this one. It's just because of the COVID, we weren't able to invite him face to face. Anyway, we'll still be expecting to see almost all of you until Sunday. Maraming salamat po.
Thank you. Mike?
Yes, I would like to mention as well that we'd like to thank, of course, Kuya Allen for inviting our keynote speaker, Dr. Michael Brand. It will be relevant and significant for him to have as our keynote speaker, especially when we intend to embark on continue to embark on the advocacy of our Palace Zero BDI. It's truly significant that we have him with us. Maraming salamat for inviting you, Kuya Allen. And of course, I'd like to mention as well to Cathy, thank you also for your support, Palace Zero BDI campaign, and for readily accepting me to do live demos during the course. Maraming salamat. Thank you, everyone.
Thank you, Ike. So the link for tomorrow and the next day will be the same as the link this afternoon. So you can just click your link for this afternoon. You can go into the sessions tomorrow and the next day. Is that right, Jeff?
Yes, Mon. Tomorrow, they have registered already for the virtual. So once they go through there, the whole 2 days, they can already access it.
Okay, so indeed, it was a great afternoon in spite of this pandemic. Thank you to all the participants for attending. Thank you to our panelists, to the board. Congratulations. It was a great afternoon, great pre-Congress workshop, pre-Congress convention. So,
Kuya,
Jeff, would you like to? Yes, Kuya.
I would just like to ask everyone to clap our hands for Jeff, Domino, and Dr. Mon for an excellent work and for giving us today's event. And of course, Dr. Ernesto Tan, our president.
So at this point, we would like to thank our sponsors for today. I think Jeff will play an AVP for our sponsors. Go ahead, Jeff. Q Medtronic, another AVP from another sponsor. Ayun, kuya. Kuya. Okay. Thank you, Maxer Dynamed. So, Jeff, thank you, everyone. Good afternoon and goodbye.
Okay, thank you, Mon. See you tomorrow.
Thank you.
Bye-bye. We'll cut the feed now.
Yeah.
Thank you,